Hello, everyone, and welcome to Everything MRI AI and Innovations Forum 2024. My name is Samuel. I'm the founder and CEO of Everything MRI, and I'm joined today with Julian, COO of our company. We're going to be running and hosting this event for all of you. It's a great pleasure to see around 160 people joining in live for now. We have more than 700 people registering, so I'm sure this number will grow during the webinar. I would like to start by thanking, of course, our speakers for doing what they're doing here today, joining out of their busy work schedules, doing the presentation for all of us about this fracturing, but a very enlightening topic, and also for being present for the roundtable there later on we'll be doing. Talking about the roundtable, I have to just let everyone know that most of the recordings, the presentations were recorded for make sure that the internet connection is not going to be an issue during the event. However, rest assured that all the presenters will be live during the event. They are watching, they are here to reply to any of the questions that you have. So you have the Q&A box at the bottom of your screen. Just pop all the questions that you have there, and we'll be gathering them and possibly answer some of them either written down or during the roundtable as well. Dr. Christina Malamatenu, one of our speakers, unfortunately won't be able to be here today for the roundtable discussion, but she sent us an amazing presentation. Please stay tuned to watch it. It's a really enlightening one, something that I'm looking forward for you to watch as well. I would like as well to thank our sponsors, 𝐷𝐷𝐵 and Pearl Technologies AG, for helping us putting this event together and also for supporting us throughout the whole year. So a big thanks for all of them. And of course, I would like to thank you all for attending on a Monday evening or morning, wherever you are at this point in the world, for joining us and trying to discuss a little bit about AI and how this is going to change our careers in the future, or actually in the near future, in the present sometimes as well, depending where you're working. Just a little bit of housekeeping in terms of the event. So we'll start with the event with 15-20 minutes presentations from our speakers today, and then we'll go straight to the roundtable. The last time we had this kind of events, some of you joined us, I'm aware of that. We had the break. We're not going to do that break because the event was kind of long. So the event today will take no longer than 3.5 hours maximum. Okay. So if you have any questions or any doubts, feel free to just text us. You can email us. You can just text us on LinkedIn. We're going to be active and we can basically answer to anything that you have in terms of questions or doubts. Please use and abuse the Q&A box. We're going to be having a look on it. And yeah, that's basically how the event is going to be run. So now I'm going to pass to Julian, our COO, and he's going to be leading you guys through the journey that we have prepared for you today. And I'll see you again more or less at the end of the event. All right. So I hope you all enjoy it, and we'll see you soon. Julian, please take over. Thank you.
Hello, Samuel, and thank you for the warm welcome and introduction to the Everything MRI AI and Innovation Forum 2024. I have to say, it's definitely a pleasure to be here today among such a diverse and esteemed group of individuals from all around the world. And as we gather here today, it's also my privilege to introduce to you the overarching theme of our discussion, which is artificial intelligence and innovation in MRI and the medical imaging field. And as you can probably imagine, in this sort of rapidly evolving landscape, AI holds like a massive potential to revolutionize our approach to medical imaging. So throughout our sessions, we will focus on the transformative impact of these new AI technologies, exploring their application, their challenges, but also the future they promise to the MRI community worldwide. So I'm not going to lie, there is a lot to cover. The sooner we start, the better. And MR users located from all around the world, I'm very glad to introduce to you the first speaker of the day. So allow me to welcome Doug Boyd back to what is his second Everything MRI event as a speaker. He's actually the only speaker to have this sort of acknowledgement so far. Doug has been an MRI technologist since 1992, bringing a wealth of experience from renowned healthcare institutions. Recently, he supervised one of the largest MRI departments at the Phoenix VA hospital in the United States. but he's also a very renowned national lecturer with interest on emphasizing things like MR safety and student education. An advice he usually gives to his students is, don't wait for tomorrow, start today. I'm pretty sure I'm gonna need it as well. And today, in fact, Doug is here to kick off our discussion about AI innovation, and he's going to do this with a presentation whose title, I think, tells quite a lot about the complexity around the topic. So the title is AI, the Good, the Bad, and the Ugly. Ladies and gentlemen, again, our first speaker today, Doug Boyd.
Good day, everybody. My name is Doug Boyd, and I am an MRI Program Director for one of the colleges here in Phoenix, Arizona. First, I want to say thank you to Everything MRI for having me on this wonderful conference and to also host this conference. Thank you, Sam, Jillian, and your team for putting this on for everybody. Very excited about talking about artificial intelligence, the good, the bad, and the ugly. Interesting subject. We use AI every day, and going to hit some high points on AI, especially in the MRI industry. So let's go. First, I want to go over my disclosures. The following information reflects my views, opinions, and experience. This presentation content was prepared by me. All information in this presentation is for illustration only and is not intended to be relied upon by the reader for instruction as to the practice of medicine. Any healthcare practitioner reading this information is reminded that they must use their learning, training, and expertise in dealing with their individual patients. This material does not substitute for that duty and is not intended to be used for any purposes in that regard. Okay, so first, AI started back in 1950, believe it or not. And how are we using it today? We'll be getting into a little deeper into my talk. Also, we're going to talk about AI just in MRI. We're going to talk about the pros of AI in MRI, the negatives of AI in MRI, and how we can take all of the AI information that we've learned, especially in the last 3 years, and incorporate it in our safety guidelines. Then we're going to uncover the ugly. I'm a big movie buff. The movie Terminator with Arnold Schwarzenegger. I'm sure many of you have seen that movie as well. Big AI on that movie about robots. So talk about that a little bit as well. And then talk about conclusion and hear about your thoughts as well. So first, again, 2 movies that reminded me what AI is back in the day. Alien, 1979 was one of my first movies that I saw at a drive-in movie. If you guys remember back in those days, the drive-in movies were very popular back in the late 70s and early 80s. And the movie that really struck me when I was building my project on AI was The Terminator, which was released back in 1984. It started to seem very real after that movie, Terminator. I guarantee a lot of us were thinking about, boy, is this really going to be our future? So how do we use AI daily? Well, first thing that comes in my mind is our cell phones. We use our cell phones on a daily basis. If it's for apps, just looking up information on what we're doing, or if it's depending on our job, if it's just to cruise the net for social media. But it's interesting on the cell phones, and I'm sure, and I want to get your thoughts on this as well from everybody, is it's amazing when you go on a website on a particular subject. And then when you're scrolling, it's amazing that that subject that you're looking at comes up repeatedly. It's amazing. So you don't have to really try very hard because that AI just really kicks in on our cell phones. So let's talk a little bit more in depth on the social. It's another comparison, but it was really launched, when we started with Facebook in 2004. And then it expanded to other platforms like Twitter, Instagram, TikTok. I know we all look at it. So Twitter started in 2007, followed by Instagram in 2010, and then finally with TikTok in 2016. I think the best comparison for this current meteoric rise in AI was the era around the early 2010s when there was an explosion of these apps. We talk about it today. There's an app for that. This is quickly turning into, there's an AI for that. As with the exponential increase in apps back then, the amount of good and sometimes bad AI apps flooding the marketplace means the learning curve is steepening. How do we keep up with it all? And I just learned the right way to say BT. So let's dive into the pros of what might talk directly into the MRI industry. My first experience using AI in MRI when dot engines came out. This really helped us optimize protocols, especially for new technologists that are in the field, to have that standardization throughout the entire department. Also, with dot engines, it helped shorten the scan times. Now, let's take this a little deeper. With deep learning and air recon has taken this much further, especially with image reconstruction. Basically taking AI algorithms that can reconstruct high quality images from undersampled or noisy MRI data. So what does that mean? Basically, it's taking that background noise and removing it. But we do have control of how much background noise that we can take from that. So traditional MRI scans require a large number of measurements leading to long scan times. AI-based techniques can accelerate the imaging process by filling in that missing data, resulting in faster scan times while maintaining image quality. So using Sense or some of the algorithms that we're using today to compress and use parallel imaging. Again, deep learning and air recon just took that a little bit further. Now it's able to remove that background noise, which equals out higher image quality. Also, with using deep learning and air recon, we can also decrease our slice thickness and get better resolution. That's exciting because with some of the smaller pathologies that we can't see, now we can at reasonable scan times. As before, some of these scan times were 7, 8, 9, 10 minutes long. Now with deep learning and air recon, we can bring those scan times down to a minute or 2 minutes. The first impression when I saw a lumbar spine, the first time I saw AI with deep learning, they were running a sagittal stir of the lumbar spine, and the sequence before deep learning was added was about 3.5 minutes. Well, when they added the deep learning algorithm to that sequence, it brought it down to 42 seconds. That's amazing. It's great for patients, especially patients that are claustrophobic, really sick patients that that we see very often. We get patients that are coming from ultrasound, CT, and most of it's not good. So usually the patients that come to our departments are really sick. So if we can decrease those scan times and equal out the image quality or even better image quality, I support that. So this brings me to my next question. Deep learning air recon, is this the future for MRI? Yes, I believe it is. Especially with the noise reduction, MRI scans are susceptible to noise due to various factors. Like I was telling you, we get these sick patients that come down to MRI. So we're dealing with patient motion. Also, patients are having other procedures with hardware. So we have hardware imperfections. AI methods can denoise MRI imaging, enhancing the diagnostic accuracy. So let's go a little step further with artifacts, MRI artifacts, such as motion artifacts, like what I just talked about, susceptibility artifacts, metal. And then we have aliasing artifacts that can degrade image quality. With AI algorithms, we can identify and correct these artifacts, leading to cleaner and more accurate images, which equals out better patient outcome. Let's hit about automated segmentation. AI segmentation anatomical structures such as organs, tumors, and blood vessels in MRI scans. Automated segmentation assists radiologists in qualifying volumes, tracking changes over time, and identifying abnormalities. AI can predict disease outcomes as well, treatment responses, and patient prognosis based on MRI data. For example, it can identify early signs of disease like Alzheimer's and predict tumor growth. And this is where this gets really exciting with the new magnets that are coming out with the 4T and the 7T. We're really going to look at the functionality of our bodies, and using AI and the higher Tesla strengths of the magnets is a win-win. AI can optimize imaging protocols, which I just spoke about a few minutes ago, about shortening the times. Based on individual patient characteristics, we can ensure efficient and tailored MRI scans. AI algorithms can assess image quality, detect artifacts, and flag problematic scans. This will help maintain consistency and reliability across different MRI machines and operators. AI can optimize image protocols based on individual patient characteristics, ensuring efficient and tailored MRI scans. AI algorithms can assess image quality, detect artifacts, flag problematic scans. This will maintain the consistency and reliability. Like I said, with different machines, I feel that is extremely important because there's so many different, machines out there. We have GE, Siemens, Philips. So having that consistency throughout the whole industry is a win-win. So in summary, AI-driven advancements in MRI promise faster scans, improved image quality, and enhanced diagnostic capabilities, ultimately benefiting patients and healthcare providers. Love to hear your thoughts. So, negatives of AI and MRI. Let's dive in. So, when I spoke about the positives about dot engines, I also felt it was a negative as well. When dot engines really got going, I found that, especially with the newer technologies that were coming out, I saw button pushing. Just because it set up the scan, it set up the placement of the scan, it had the protocol all ready to go. So basically it was, you select the scan, you send it over, and you hit go. I've been in the MRI industry for 30 plus years. I believe as a technologist, trade-offs is the most important part of our job. With dot engines, it eliminated that. However, it did help shorten scan times. And with that, the facility just added more patients. With deep learning and air recon, again, now they're even faster scan times. Now, I've also seen rads on the fence about this, just because when they hear filter, okay, a lot of the, what I call old school radiologists feel that they're going to miss things, especially when they hear filter. So it was a big learning curve for the radiologist. Still, I've talked to a lot of the radiologists, and some of them still feel that with adding deep learning and air recon they're going to miss something. Love to hear your thoughts on that. Now, my biggest concern with deep learning and air recon. Yes, it is the future for MRI, but is it going to be more, or is it going to increase the burnout for MRI techs? Are we going to have more mistakes happening because the actual scans are going to be shorter, the time spots are going to be shorter, so that equals out to more patients. I know some centers are doing 40 to 50 patients a day. That's a lot. Doing that every day in and out and only having 10 to 15 minutes to perform an MRI, mistakes are going to happen. techs are going to keep getting burnout. So how do we balance that? So balancing it equals MRI safety. MRI safety has to be number one. We really can take advantage of using AI for MRI safety. Instead of really focusing on adding more patients, getting faster scan times, we can keep the faster scan times, but give that time back to the technologists so we can screen properly. I know back in the day when I started MRI, over 30 years ago, I had 30 minutes to sit with that patient and screen them, get a history from them, take the time to position them, actually talk to them one-on-one instead of walking them back in a hurry, putting an IV, getting them on the table, getting them scanned. Also, we forgot one factor, getting them changed. We're all trying to do that in a 15-minute window. I personally, this is just my opinion, I think it's ludicrous. So my vote, and I would love to hear your thoughts on this, is if we're gonna involve AI with air recon and deep learning, give some of that time back to the technologist. We really do need it. Again, I would love to hear your thoughts on that. Finally, the ugly. What I just talked about, we can take advantage of this. More time to screen properly, more time to position properly, take better histories. Can't tell you how many times a patient has come into my MRI department for an order for just a brain MRI. As I'm taking the history and screening them, I find out that it changed from just a brain without contrast to a brain with and without contrast and adding IECs. That's a big time factor. That changes that will put your schedule behind at least 30 to 45 minutes. So having that time to take better histories and also taking the time to position properly is so important. And then the screening aspect of it, having that time to do the timeout procedure that everybody should be doing, making sure that we're checking all the boxes. MRI centers taking advantage of AI. Well, adding more patients to the schedule, shortening patient time even more, which equates to more accidents, I feel. We don't need any more accidents. As we've been seeing the last year and a half on social media, that accidents are happening on a daily basis. We, as a MRI industry, need to take more control of this. We need to, as technologists, have a voice in this. So I would love to hear your thoughts on that. Finally, we must look at AI and MRI. Adding deep learning air recon may be good in many ways. Is this going to increase our accidents in the MRI industry? If it's not properly placed and we don't have SOPs and policies to back it up, in my opinion, yes. I believe we could take advantage, again, split the time up by performing better screening and taking better histories. We can still decrease our times, but we should not shortcut our patients as well. At the end of the day, it's all about patient care. Love to hear your thoughts. I'm very excited. I want to thank Everything MRI for hosting this event. Sam, Julian, you guys are the best. I'm so impressed what you guys have done in the last year and a half for our industry. Please keep it going. It's exciting to see what you guys are doing. And I just want to say thank you. It was an honor speaking in front of everybody today. And looking forward to hearing your guys' thoughts on my talk. Have a great day.
Thank you so much, Doug, for this insightful overview of the upsides and downsides of AI. Your analogy with Terminator really struck a chord with me. Even back when I was a kid, I was particularly fascinated by the remarkable level of technology depicted in that movie. And now here we are. While we are not quite at the Schwarzenegger level of intensity, we are certainly seeing technology geared more towards patient care. Let me say that I also particularly appreciated your acknowledgement about the potential drawbacks for frontline healthcare professionals like MR radiographers who might face drastically increased scanning demands. Just like you mentioned, we'll need to take a very balanced approach towards AI implementation, prioritizing its usage in improving things like MR safety and the overall patient care. So let's move now to our second presenter of the day, which I'm pretty sure is quite a familiar face to many of you working in the MRI field. He's a dear friend of Everything MRI. His name is 𝐁𝐈 𝐀𝐈 𝐷𝐈 is an MRI radiographer who has been in the MR field since 2006, predominantly working at the Oslo University Hospital. He also serves as a consultant MRI application specialist for Bayer and Arista. On top of that, 𝐁𝐈 is also running this very successful YouTube channel where he shares MRI from basic to advanced topics, tips and tricks, tutorials, and troubleshooting. 𝐁𝐈 is here today to share a lecture completely focused on the capabilities of this new AI technology in MRI. His presentation title is Artificial Intelligence, MRI on Speed and Precision. 𝐁𝐈, the stage is all yours.
Thank you for the kind introduction, and thank you all for joining us in this event today. I'm very happy to be a part of this event, and we're honored as well. And this topic, I just love this topic, AI. So I'm going to talk about AI, MRI on speed and precision. So let's jump into this. I do not have anything to disclose. My outline today is artificial intelligence and MRI sequences. I'm going to talk about, is it useful or is it gimmick? I can give you a few examples there. And also, what kind of impact does this have for our work currently? So is it a benefit or is it pro and cons and so on? So AI. A wise radiographer once said, will AI replace radiographers? Radiographers who know how to use AI will replace radiographers who don't. So by this, it means that AI is already here. So it's expanding itself very fast. So we just need to get a hold of it and know how to use it. So it's well said. As you can see, there's a big intersection right here. Many roads. So there are many roads to the same thing, AI. The only different vendors today have somehow different deep learning or AI. You have Siemens, which is called Deep Resolve, GE, ARRI, CONDL, Philips, Smart Speed, United Imaging, UAI, FI, Canon have AI, CE. So different names, and some of them have gotten further than others on the AI development, but nonetheless, they are here and they're expanding very fast. So different roads, different approaches. Nonetheless, in the end, it's all about flexibility, efficient, and precision. So let's shift gear to useful or gimmick. This is very known golden triangle. For the first time, if we read MRI books or articles, you will see this golden triangle right here. This is a trade-off between what you see in the front here, relative SNR, you have the scan time and the resolution. What does it mean by that? And that means that if you're going to have very good high-resolution images, that will lead to less SNR, and we need to compensate that, and then the scan time will increases. So it's a trade-off, right? Good images, long scan time. So this figure is taken from a paper which is in its barcode. So if you're interested in reading more about the SNR in general, when it comes to basic MRI, I really recommend you to take your phone and take a photo of that barcode right up in the corner there. So with AI, we're able now to break barriers with AI. So by that, I mean that you can have high resolution images, short scan time, good enough SNR. So we are breaking that barrier right now with AI, which means that's very, very interesting. So let's move on right here. This is just an example. So on the upper row right here, there's AI is off. Of course, you will not give any images like this to any radiologist, right? But this just shows that you can really push the limits. So down below here is the same sequence, but here is AI on. So you can see it's a denoising function. So the noise is now gone and you get clear, tack, good images. And the good thing about this is the speed. Look at the scan, 46 seconds. It's no chance with the AI. 1 minute, 55 seconds, 2 minutes. So if you look at this stir sequence right here, for the first time when you read about stir, you know that stir is a lack of SNR. You cannot have high resolution, and you need to use a lot of scan time to obtain good images. However, with AI now, we're really changing this. So we can have high resolution images, short scan time, and this is really game changing. The thing is that stir is old, but it's still gold. And now we're pushing it to the next level with AI. This is a paper which I wrote for not a long time ago. It's just released recently, so in the Marathon Flash. So how I do it. So there's a lot of talking about sedation-free MRI these days. Of course it is, because we are now able to scan faster, have good images to give a proper clinical answer to a diagnostic. So the kids, we really want to have a sedation-free or anesthesia. So if the kids can lie there for like 10 minutes or so for having a whole knee exam, of course we really want that. So there's a lot of patient preparation, fixation, and then we have the AI on the sequences, which makes things faster. So it's a paper right here where I share a lot of protocols as well. So if you're interested, there's a barcode right here. Just scan that and it will lead you directly into the paper. For what organs can I use AI? Well, you can use it for everything. It's just what you have it available for neuroimaging, head neck imaging, MSK, and then you have, this is image of the costa with metastasis. It's a very difficult area. It's a lot of, you can see air tissue interference right here. It's a lung. You can see respiratory artifacts from the cardiac, from the breathing. But if you're able to scan fast, able to have tac shock images, you're able to catch this like we did right here. So that gives us opportunity to image more difficult cases what we used to before. So when we first got AI at the hospital, it's like for around 1.5 years ago on 3D scanner. And you can see this is the first test I did. This is on this side right here is the conventional, which took around 2 minutes and 20 seconds. Before AI, I found this one is not that bad. It was good, but when AI next to it, it's like, whoa, what did I really use back then? And with this, it is 25% reduction in scan time. Now it's only 1 minute and 45 seconds. So this was the beginning of the AI when we got it, and we didn't really know we did. So we took on the AI and changed a few parameters, still turned out very well. So it's very easy to use. It's not difficult at all, but this is not the one we use per day. We even tune it even more. So it's very funny looking at the protocol where we did back then compared to now. It's like thinking, what did I really do back then? So it's learning by doing, and I still learn a lot from 1.5 years to now. So AI expanding very fast. I still learn new tips and tricks. And that's why I also try to share with you guys. So this is just not an example without AI. So let's look at the T1 right here. So without AI and with AI, you can see the noise is denoising. So you get tac shock images. You have a high resolution, high parallel imaging, a lot of coverage, 32 slices, and only 52 seconds. On this side, you have a PD tube spectacular fat sat of the same knee. Without AI, with AI, you see here, no noise, and tac shock images, only 1 minute. This is just not an example of the 4-foot. This is a T1 weighted image, 40 slices, 17 seconds. PD fat sat, 13 seconds. Axial plane or transversal plane, 19 seconds. Then you have a sagittal, 22 seconds and 20 seconds. You can see clearly here that the speed is on. So it's going very fast, and the total scan time from the 5 sequences is around 1 minute and 31 seconds. Let's go for next one is the TMJ. You can see here, 2.5 millimeter, 23 seconds, 13 slices on each side. The TMJ, 25 seconds, 1 seconds with T1. Close, PD, tubes per echo, 22 seconds, and then open mouth, you can see here, it's different, 22 seconds. For the whole exam of this one, this took around 1 minute, 53 seconds or 2 minutes. I was done on a 3T. This is also done on a 3T. where we combine high acceleration, 9 seconds, 80 seconds, 40, 28, 44, so 5 sequences with high resolution images for around 2 minutes or so with the elbow. We know that elbow is a very difficult exam, and just lying there, either as a Superman position, which is not good enough for elder people, or you have the hand next to you lying in a normal position, is difficult, and it's very difficult and hard for the patient to lie still. So it's very important to be able to scan fast and precision, also have good images. So let's shift to the last gear right here. What kind of impact does this have on our work currently?
Video taker, sorry, I came.
Percentage of the different organs. So the reason I have 5 different organs right here is because our hospital is divided in 5 different organs. So we have radiologists, which is only doing head neck, only neuro, only MSK, pediatric, and abdominal. So we have 5 sections. Our radiographers, we are scanning everything. Pediatric is a question mark. Abdominal is also a question mark. The reason for that is that we're not doing much pediatric on a 3T, nor abdominal imaging as well, because we have 1.5 Tesla, which is taking care of these type of cases. Only most special cases go to 3T when it comes to pediatric, and but very rarely. However, head neck, we have a lot of that on 3T. So we are now saving around 16%, neuro around 23%, musculoskeletal around 54%. Why do we save a lot when it comes to MSK imaging? The reason for that is that on our 3T and AI, we only have available for 2D sequences per day, but we know that they're expanding very fast. We're really looking forward to expanding to different type of sequences as well. But for neuroimaging, we have a lot of 3D, and for head neck, we also have a lot of 3D. Nonetheless, when we upgraded this scanner from old scanner to a new scanner, which made AI possible, we had to promise the hospital that for the economics, we need to at least increase the efficiency with at least 10%. But look at the numbers right there, and we're feeling very comfortable that we expanded that so much above 10%. So we are very much safe, and it was very surprising that we could save this much in percentage. So with AI available, it leads to many roads. You can set up more time for inpatient and emergency patients. This is what we are doing right now. You can have less delays during the day. That is very true. It goes fast. And if the patient's not lying still, you can do a rescan, even though you will be delayed. And of course, reduction of sedation, anesthesia. So this is a very important point. We're able to solve difficult cases, also important. Multiple exam in one day. What do I mean by that? Let me get back to you on that one. Or you can have more patients on the schedule. We didn't choose this one currently now because we have more time now for inpatient emergency. So this is per day, but we don't know how it changes in the future. But you're able to have more patients on schedule with AI. So multiple course, multiple exam. This is just a video I did on my YouTube. So if you're interested, just scan this barcode. The reason I did this was that I just want to see what kind of hardware I could put all together to scan it once with one reference scan and do not have to move the patient in and out, change the codes. So you can do everything from TMJ, liver imaging, hand wrist, and then foot ankle. This is extremely, we're not doing this daily. I just wanted to test. But what we're doing that, this is the case I want to show you. What we are doing that, this is a 6-year-old, no sedation, osteochondral both wrist, multiple operation on the right wrist. So now we want the mapping due to the malignant transformation. So this is a 6-year-old. So we did a right wrist with 3 sequences right here, 6-year-old. So you can see here the scan time is around 3 minutes or so. In all that, without AI, we need to take this patient back because the scan time would have been too long. And you know, when a 6-year-old kid, they cannot lie in the scanner for so long, they will lose the patient. And it's very difficult for them to lie still that long. So what we're able to do is that we're able to run both the wrist and within, you can see the scan time right here. So within 10 minutes or so, we're able to do both wrists, do a little change in between those wrists. She's not coming back to us, and we did all exams in one day. It's really good possibilities to especially these kids. one of the last slides I want to show is that I talked to a radiologist once, and he said that with AI, my head is not heavy at the end of the day. What does he mean by that? It's so true, because if you are looking at images which is not clear, crisp, and you're not confident in what you're seeing, and you need to use a lot of time to look back and forth, scroll back and forth, of course, your head will be heavy. Compared to looking at the tack sharp images, you get good, clear images, you're confident in what you're seeing. So after he said this to me, it makes sense. So with AI, my head is not heavy at the end of the day. So it's a positive effect on AI for radiologists as well when it comes to looking at clear images. So at the end of all, thank you all for your attention. Thank you for watching my presentation, listening to it, and hopefully something will be remembered. And remember, there's always about listening, discussing, sharing, and then adapt. If you have any question, don't hesitate to pop an email to me. And if you're interested in my YouTube, check it out. Scan this barcode. We have a lot of tips and tricks videos right there. So with that said, thank you very much.
Thank you, Buck. I'm really pleased you shared this lecture with us today. And I have to say, I'm particularly impressed by the relationship between the image quality and the scan time you have presented. As an old-fashioned radiographer myself, who started out, I think as you did, with a 0.2 Tesla MRI machine, achieving such a high image quality with a sequence acquisition of 1 minute or probably even less than that, it seems something we probably never would have imagined when we started our careers in MRI. Also, thank you for highlighting the impact of this new technology in the pediatric field. We know it's quite a challenging area due to the limited patient cooperation. And from the example you have displayed, it seems AI could truly be a game changer in this context. Okay, time now to go ahead with our fantastic lineup. And the next speaker I'm very happy to introduce is Dr. Amrita Kumar. Dr. Kumar is a consultant radiologist with specialist interest in breast cancer screening and AI implementation in healthcare. She's the chair of the AI working group at Frimley Health, supporting the development of an AI framework for its safe and effective deployment in different clinical pathways. She's also the chair of the AI Innovation Specialist Interest Group at the British Institute of Radiology, which aims to address numerous challenges in the AI implementation in medical imaging. If this doesn't sound enough, in 2022, she has been also named the top 50 innovator and top 50 influential woman in the United Kingdom for leading innovation in the use of AI within the NHS. As you probably know, the implementation of AI is not limited to the MR field only, but is also extended to other imaging modalities. So Dr. Kumar will help us today to understand a little bit more about the benefits of using this new technology in the breast imaging field with a presentation titled AI in Breast Screening, Clinical Use and Patient Interface. Amrita, whenever you're ready, feel free to take the lead.
Hello, everyone. My name is Dr. Amrita Kumar, and I'm consultant radiologist and clinical AI lead at Frimley Health. I'm also the chair of the AI and Innovation Special Interest Group at the British Institute of Radiology, and it gives me great pleasure to present the next topic, which is on clinical use and using AI in breast screening, in particular, looking at the clinical and patient interface. When we look at the HEE framework for this section, the role is to really look at the clinical use in context of what the patient confidence is in AI-assisted clinical decisions. Now, as I'm sure most of you are aware, given that AI is at an early point of clinical implementation, patients are being used in groups to get their views on, but there's not that much evidence to show how they're being involved actively in implementation. So I'm hoping to give you a very good breast screening scenario because the setup and the workflow gives a great overview of how clinicians, clinical workflow, and patients all can interact with each other when we look at implementing AI in this workflow. So moving on, I'd like to just start off this presentation by addressing the challenges in breast screening, because I'm mindful of the fact that not everybody may be familiar with the breast screening pathway in this country, how it's set up, why it aligns quite well to thinking about AI implementation and how we could use AI in different points to interact and speed up diagnosis or actually the diagnostic phase of the breast screening pathway. Then we'll look at the various roles of AI in those pathways. And then really what the patient interface is as far as patient perception and acceptance is at this current point in time. I'll end by challenges, but I'm sure that you have addressed challenges in your previous webinar recordings as well. So a brief overview about breast cancer screening. We know that breast cancer is the #1 cancer in women in UK, and about 1 in 8 women will be diagnosed with breast cancer during their lifetime. The breast screening has been set up to find breast cancers early. Why is that important? Because we know that very early cancers are much easier to treat and cost less during this treatment phase. We also know that early diagnosis can result in a cure and that the evidence shows that there is a substantial number of lives saved by screening. What are some of the harms that people talk about? Really, they're around the false positives and false negatives. By false positives, it's really the extra biopsies that we do that do not yield a cancer result, that are actually benign or something else. And this obviously can cause a lot of anxiety for patients. False negatives are those cases that we have not detected that were cancer, so that there has been a potential delayed diagnosis. And you can appreciate both of these things have a very negative effect on patients, on clinicians, and the hospital providers. So we know how important breast cancer screening is. Now, here I have put a slide to show the end-to-end breast cancer screening pathway. This is very important because until you have a process mapping of the end-to-end pathway, you can't appreciate the various data points where data is actually collected and where AI could interact with the pathway to either speed it up or give a better outcome for the patient. So if I start from the very top, essentially breast screening is open to all ladies between the ages of 50 and 72 every 3 years. The only caveat here is that these ladies have to be registered by the GP in this country. It's the GP centers where the batches for ladies to be invited are compiled because they're registered at those GP practices, and then invitations are sent out. Once an invitation is accepted, the patient actually attends for their mammogram. Their mammographer takes the standard 4 views for the mammogram, and from here on, it's on the reporting pile. Now, breast screening pathway is unique in that there's fairly strict guidelines that we have to adhere to. So once a mammogram has happened, these have to be read within a 2-week period. And the reading actually follows that there has to be 2 consultant radiologists, or in fact, a consultant mammographer who has reading training to read the mammogram. So it's a unique pathway where 2 humans are reporting on it. The potential outputs are that both of them agree that it's normal, in which case a standard template letter goes out to the lady informing that they've had a normal screening round and they'll be invited back in 3 years. If both readers say it's negative, then the patient now has letter go out to recall them for an assessment where they will come back at a later date, again, within a defined period of time, so that they can have some further mammogram views, some ultrasound scans, and potential needle biopsy. So a full assessment happens at the second visit. Now, if the 2 readers have discrepant outputs where one has agreed and one has disagreed, then that tends to go into a weekly or sometimes bi-weekly consensus meeting where, depending on the center, you could have anywhere between 2 to 6 different radiologists who then consent and arbitrate those cases and decide whether they're going to return it to normal screen with invitation in 3 years' time or actually recall for further assessment. So you can appreciate that in this diagnostic phase, once the mammogram has actually been undertaken, the next step is really getting it reported in a very timely manner by 2 readers so that we know whether they can be invited back in 3 years because everything is normal, or actually they will now come back for assessment, and possible at that assessment, they may have normal findings on further mammographic views and ultrasound, in which case they again discharged back into the community to be seen in 3 years' time. Or, in fact, there is an abnormal finding and they will have a biopsy, which gets done at that assessment visit, and then they get recalled when the biopsy result is available, anytime between 5 to 7 days later, where they are diagnosed with breast cancer and then referred to a multidisciplinary team for further management. And that's usually the breast surgeon, the oncologist, who then manage the patient and bring them into a symptomatic pathway where further surgery or oncological treatments become necessary. And this particular phase becomes more of the therapeutic treatment phase. So the breast screening pathway, as you can see in this outline, very much focuses on the early path of the diagnostic pathway and how much it could be speeded up, because there are multiple points at which there can be delays if the appropriate resourcing is not there for turnaround times of the reporting and assessment. So what are those challenges? The fact remains that we have an aging population, which essentially means that there are ladies living longer, and therefore there's an increased incidence of breast cancer. This obviously puts stress on that pathway because we are finding more and more cancers every year that goes on because people are living longer. Now, combine this with the fact that we are currently understaffed, and it looks to be getting slightly worse in the coming 5 years. You get into a situation where you have these longer reporting times, which then coupled with a shortage of radiologists and exponential growth in imaging requests, which leads to increasing demand on radiology departments. So it actually comes that because of these things, which were obviously compounded by the pandemic, there is a huge interest in using artificial intelligence, so AI, for breast imaging so that we can address some of these pressures, especially because, as you can appreciate in this pathway, timing is critical and resources are finite. So I haven't gone into much detail about the different technicalities of AI because I know there are previous webinars that address this. But essentially, the term AI falls broadly into machine learning, deep learning for using AI in breast imaging. We really do look at the advances in deep learning for the image interpretation side of things. And again, AI can be divided into broad AI and narrow AI. And narrow AI looks more towards computer-aided diagnosis and triage, which is something that we use when we're looking at using AI in breast cancer screening, because that's more of its initial interaction in our current clinical pathways. And something to bear in mind is not just the accuracy of these systems, but actually when we look at the role of AI, we're actually thinking what value it is in terms of patient outcomes, as well as healthcare system efficiencies. And then eventually we will look at costs as well. So when looking at evaluating AI in breast imaging, what are the parameters that I think are important? So I think as clinicians, irrespective of which stage, which area you're looking at, you have to know what are the major things to be watchful for when evaluating AI. It always starts off with retrospective evaluation, looking at companies and seeing what sort of retrospective studies they have done, what sort of data sets they've trained the algorithms on, if those data sets had generalizability of different demographics, of different ages, of the different parameters that can come into being that are different amongst geography in the country or just adjacent trusts who serve different population sets. So that generalizability and potential bias has to be looked at. And all of this evidence is looked at if you look at the retrospective evaluation and really look into detail about the training data sets that have been used. Now, companies also use their internal validation sets that once they've actually trained, they test the algorithms on. And they also have to do this on external data sets just to see how well the algorithm copes. I myself find that looking at retrospective evaluation, looking at the evidence and doing PubMed searches, seeing the publications out there really does give you an idea of certain companies and their AI algorithms in how they have really utilized this part of the evaluation. Then coming into prospective evaluation, this is currently ongoing. There's not actually that much evidence there right now, but there are multiple trials now underway, whether it's formal research or actually pilot studies that different centers are doing to see how AI could be implemented in real life for prospective evaluation. Because it's very important to know what the real-time testing in clinical pathways is going to look like, how it interacts with all the end users in that pathway. I've also noted that because obviously this is an area that is very new and there's no precedent for it, there are now national publications like the Consort AI, Spirit AI, where you can look to how AI reporting standards can be observed. So it's good to look at these national frameworks to see how they can be applied in your setting. The ones that people are usually very familiar with our performance measurements, looking at the statistical validity. And I'm sure everyone is aware of the area under the curve, which is what most companies use. And I find this a little bit falsely reassuring because most companies report area under the curve studies greater than 92%. And it's quite difficult to gauge if this accuracy was, this particular area under the curve was based on 100 studies or 1,000,000 studies, because that has a huge impact on this number. And actually, whether it's 93% or 98% doesn't give us that much extra confidence about different algorithm. I myself prefer looking at the sensitivity and specificity to see what the true positives, true negatives are in relation to the whole, and also thinking of what the total sort of positive predictive value, or potentially if you're looking at triaging, the negative predictive value is. So it's something to be mindful that there are different forms of statistical validity, but you do have to look at a measure, not just at a single point in time, but more of a continuous evaluation. And I find the sensitivity and specificity and positive predictive value and negative predictive value tends to be slightly more aligned than just using area under the curve. For me personally, I think value, as I've mentioned, is most important. Here, value to me is essentially the impact on patient outcomes over the costs needed to get you there. So the patient outcomes historically has been to do with long-term patient outcomes. So, you know, what their survival rate is at the point of treatment a year later, 5 years later. That's the traditional patient outcomes always used for the treatment therapeutic stage. And you have to be mindful that AI, we're actually looking at the early diagnostic phase where we're trying to speed up the diagnostic reporting or turnaround times for the reporting of whether it's mammograms or any other modality that you're looking at. So really it's on the early detection. Now, when you're looking at early detection, patient outcomes is very much to do with the turnaround time, because the turnaround time will lead to a faster diagnosis, at which point you not only catch the cancer and treat it faster, which will eventually have an impact on the outcomes, but you also reduce patient anxiety, patient recovers faster from surgery because it's a smaller surgery. These are factors that you have to keep in mind. So when we look at patient outcomes, it can't be the traditional ICHOMS values that we look at in the treatment and diagnostic phase is the main point. So it's something to bear in mind for the new outcomes that we look at. Then the cost. Now, there's substantial investment for AI development, whether it's in the form of IT infrastructure in your hospital or the multidisciplinary team that has to come together in a form of whether it's an AI working group or a different body that comes together that is in charge of the implementation. And then keeping in mind that there are substantial costs to training and continuous monitoring of the AI algorithm on your data set. So some of the ways that AI can be used in the breast cancer screening pathway is that when we send the invite, it can inform the frequency of screening. So use it as a risk stratification. We know that ladies, the population risk is that we screen every lady every 3 years. But now as we collect more evidence, there are other comorbidities that do play a part in increasing the risk, of which family history is just one, or having a genetic component is another. But smoking, exercising, the type of diet being maintained, being on the HRT or the pill, all of these have different risk stratification. And now there is evidence to show that combining these can give you and inform the frequency of screening. It can also be used for clinical management to reduce DNAs by identifying times, dates, and sites. It can be used for AI, for communication and information and relaying this to the patient. When we actually capture the mammogram images, we can use AI to assess the image quality for dose optimization and for quality control assessment. These are things people haven't thought about, but these are parameters at every part of their screening pathway that specific AI programs can come in to help either process or optimize or in fact speed up. Once the images are being read by consultant readers, you can use it for triage and prioritization. You can actually use it to define the breast density, because we do have national trials underway that show that increased breast density does increase the risk of detecting breast cancer. And so knowing which patients have that increased risk can be an application. And obviously when you identify a lesion, it's not just the detection, but also the classification and the characterization that could inform the kind of treatment oncologists give. Once the patient comes in for assessment, we can use AI for mammogram reading, for ultrasound detection, for MRI reading, and for pathology, where histological analysis can also be carried out in part. I've just added this slide because I always feel it's important that aside from the statistical validity, there are multiple other things that you have to bear in mind when looking at AI, and specifically because pretty much every body part, whether it's breast screening or bowel cancer or lung cancer, there are multiple AI companies to choose from. So I've just gone over the different types of evaluations in terms of research evidence. Now, whereas that is a very important element, there are other things to consider. And we know this because we've been implementing AI in our clinical pathway. And it's not just the research evidence, it's actually how it fits into the user workflow, which is why it was important to take you through the workflow to know exactly at which point it's fitting in. So combining the user workflow alongside the existing IT infrastructure that you have is something that has to be thought about from the first. I think personally is just as important as the research evidence of the retrospective and any prospective evidence AI companies are using for that particular body part. How well it works can only complement if it actually fits into the clinical pathway. And then looking at value, because all of these things have to be quantified to an extent to justify why, in a time when all of us are financially squeezed, we are going to divert money to AI, because it has to give us the metric or the outputs that it helps with, so that if we are reconfiguring our finances, it's worth our while. Which is why a lot of prospective workflow service evaluations or pilots being done are looking at what that value looks like in terms of monetary, in terms of speeding up the diagnosis, because it has to be justified when putting up a business case to pay for the AI that could help the clinical workflow. And I always say, do look at the team that you're possibly thinking of working with, because the team does matter. The team has to have a clinician on board who realizes what the workflow is. There have been multiple companies that focus on the accuracy of detecting specific things on a chest x-ray, on a CT, but actually they don't seem to have grasped how this actually would implement into a clinical pathway without huge financial investment that makes it quite economically unviable. So making sure that the team, the type of people who approach, are vested in mutual sort of value outputs that both sides have agreed upon, so that you can make it work for your clinical pathway. And here I'm mindful, because even though we know that working in, say, the National Health Service, even for breast cancer screening, we follow the same process and protocol, just the setup of different centers can just be slightly different to one another. So having that interaction and that visibility for the end-to-end working pathway is very important, and seeing how the team interacts with your team. I've given a few examples of how AI is currently being used in mammography at pilot sites. And here on the left, you've got the 4 traditional mammogram views, and you can see the red region of interest highlighting the cancer in these images. And this is where the pilots are identifying not only the accuracy with which it detects abnormalities, but can it also be confident when it says something is normal. Now, multiple vendors are currently being evaluated in the UK. This has actually led to the National Institute of Health and Care Excellence, NICE, to publish a medtech briefing that illustrates how AI technologies may improve performance and save time in interpreting mammograms. But these are, again, largely based on retrospective data. So the key uncertainties remain that there's no actual published prospective clinical studies, but these are being thought about and planned as we speak. And there are obviously very few clinical validity studies that have been used, that have used effectively UK data sets, which are representative of the target population for screening. So again, this is being addressed by the UK National Screening Committee, which has issued interim guidance on the use of AI within screening. And if it's of interest, I've listed the 2 documents that, if you are interested, even if you're not in the breast cancer clinical pathway, these are 2 very well-written documents that may well inform other medical specialties as well. But it gives you an idea of what is being looked at and how future prospective trials are being evidenced and mapped out. There are multiple AIs now also used in ultrasound. There's no active pilot ultrasound use that I'm aware of, but there may well be contracts being pilot study contracts being considered this year. So the use of AI is emerging in ultrasound, where AI-based decision support systems can assist radiologists and breast sonographers in analyzing breast ultrasound images. And they automatically generate the probability of malignancy. So in this particular lesion, the AI has again found a region of interest and boxed it off in the blue dotted line. And here, this is actually in our grading system. We use a 1 to 5 grading system where 1 is benign, 5 is cancer. And the AI can give you additional quality control outputs to say what it thinks. Now, usually anything that is deemed grade 3 to 5 ends up having a needle test by most centers' departmental protocol. But I think the value here from the research suggests that when something is really very benign, the AI tool can confirm its benignity and therefore reduce benign breast biopsies, which obviously can have a great impact on a patient's anxiety and of taking time off work. So there are multiple costs associated with coming in and having a breast biopsy, let alone just the biopsy needle and time of the clinician, patient, and hospital providers. So it also can therefore increase the positive predictive value of the biopsies that are being undertaken using it. Overall, the impact of AI in breast cancer screening, it has huge potential patient benefits, which include faster cancer diagnostic pathways by triaging cancers using AI. And here I'm talking about triaging, because as I've said, we are in breast screening, have the luxury of having 2 human readers. So one day we can, once the evidence shows, think about removing the second human reader. But even prior to that, looking at how AI could help with just triaging cancers in centers where there is a huge backlog, so that even though 2 humans will read every mammogram, there is an element of triage and speeding up the abnormal mammogram reading ahead of the normal mammogram reading. Because if a center has 6-week backlog, if the cancers come up at the point of the mammogram, if the cancer alerts come up at the point of the mammogram happening, those could potentially be read first, and therefore you'd save 6 weeks, for the diagnostic phase, which impacts the 62-day cancer pathway immensely. So for triaging cancers using AI, while at the same time reducing the number of unnecessary mammogram recalls and benign ultrasound biopsies, reducing extra clinic visits and the anxiety associated with these visits. So the real focus is on lives saved, time saved, cost saved. AI also has the potential to provide democratization of care by reducing the variability in recall rates between different screening centers. I think an exciting scope for me in the potential use of AI in breast screening will be to reduce the incidence of interval cancers. And interval cancers in particular are those cancers that have grown during a 3-year screening cycle. So ladies will have the mammogram every 3 years, but we do know that the faster, more aggressive cancers appear well within those 3 years. So by the time the next screening round happens, a big cancer is already there. So there is some evidence to show that AI could detect those, whereas in the prior years, screening mammograms, maybe they weren't being picked up by the human eye, but tech can, looking at different features of the mammogram, pick it up. But this is very much being looked at. And so picking up those aggressive cancers and reducing the interval cancers is an exciting scope. It would be of great benefit within the breast screening centers, and it would help in aiding the adoption of AI and therefore improving long-term survival of patients. From my side, as with any new technologies, there will need to be a significant investment in IT infrastructure alongside AI implementation pathways, including patient acceptability and clinician acceptability and training, if the benefits are to be realized. And at this point, I've brought up the evidence that is currently there for the patient perception and acceptance. And I think we're lucky because work has been underway in the breast screening side of things as far as this interaction with AI is concerned. We now do have a few prospective studies that are available that show what participants in breast cancer screening program think about the introduction of AI in mammography. And it's quite interesting. The UK paper from 2021 at MRAD, which is a conglomerate of a few NHS trusts in East Midlands, basically investigated the females' attitudes, both current and future users of breast screening, towards the use of AI in mammogram reading. And in the study, the females of screening age were less likely than females under the screening age to use technology apps for healthcare advice. this is interesting because this is a generational thing. So using tech apps obviously is a lot easier the younger you are. We know that when we look at people younger than us. But what was interesting is that women of screening age were more likely to feel positive about AI being used to read mammograms. So this suggests that efforts to improve patients' knowledge of usefulness of technology in medicine is still needed, and it should be more accepted as we provide more information. The latest paper from Italy that actually has a breast screening center set up similar to ours with 2 human readers stated that despite recent breakthroughs in the diagnostic performance of AI in mammography, the general population seems not to support a fully independent use of computers without involving human assessment. And again, here I agree, because I don't think anybody at this stage is ready for autonomous use of AI, because we're right now building our trust to see how AI comes in. So I think looking at the triage and prioritization end, where AI complements the existing radiologist who's reading, and it's helping them speed up that triage process or the reporting turnaround, is a good place to start. And most of these screening females approved the introduction of AI, although only as an adjunct to the radiologist's judgment. One of the things, interestingly, obviously, that we are looking at is the accountability was mentioned, because again, patients want to know that there is accountability. And who is it? Is it the AI? Is it the clinician? And this is an ongoing conversation. And I think as we look at it from more of a triage and prioritization point of view, in my opinion, this rests firmly on the radiologist who is still using AI at this moment in time as a potential diagnostic aid. The key question is really how to convince patients to embrace AI innovation, in my opinion. And I think patients, radiologists, healthcare providers, and policymakers really need to come and work together, starting from the consideration of patient values and preferences. Patients are the key end users in this clinical pathway. So even though I've gone through all the things the clinicians do and the way the pathway works, really we're using this to help the patient. So I think the studies and surveys that are there really inform that to keep the patients very much part of the implementation process. And I myself find that when we are doing trials at our centers, keeping them informed so that they know that at this point, we're very much looking at it to aid us, seems to have a very positive effect, because even patients know that the NHS is stretched and that we're doing what we can to speed up the diagnosis of cancer. I've ended my webinar by including the challenges slides. I think a lot of it has been addressed in a lot of the previous webinars, but no presentation on AI is complete without looking at the challenges. I won't go over all the details, but I have left it here just so that you're aware that the many technical, organizational, governance, legal, and regulatory challenges are there, and to be aware of all of them as you think about implementing. And I hope this overview has given you what the practicalities of implementing AI in the breast cancer screening has been. So thank you for your time.
Thank you, Amrita, for this engaging focus on the impact of AI in breast screening. Allow me also to greet you for reminding us about the importance of evaluating the different AI algorithms and how they are built. Sometimes when we talk about AI, we tend to think of it as a unique entity that once used, it will generate like a predetermined effect. However, as you correctly pointed out, there are plenty of AI algorithms. Most of them are trained in different ways, and therefore they also perform differently. So it's really important we have a solid process in place to understand a little bit more which type of technology aligns more closely to what we are looking for. It's also great to see how AI is supporting clinicians in the decision-making process, resulting in benefits from a patient care perspective. As you stated, with fewer patients recalled, there is less anxiety, reduced overall costs involved, and I'm pretty sure there are still a lot of advantages yet to be identified. One of the challenges instead you mentioned about AI implementation is dealing with governance. And this brings us straight to the next speaker, which is Dr. Cristina Malamateni. Christina is a diagnostic radiographer with major expertise in MRI. She's an associate professor and the co-director of the postgraduate program in radiography at City University of London, which I believe is one of the very few university programs, if not the only one, which has like an AI module completely designed for radiographers. Christina is also a renowned researcher in the medical imaging field with more than £3.2 million in research grants in her name. Her area of research revolves around AI implementation and education in radiography, person-centered care, and supporting the workforce in its recovery after the COVID-19 pandemic. Today, Christina has decided to share with us a presentation on a critical step of AI implementation, which is the approach with clinical governance. So without further ado, I present to you Dr. Christina Malamateanu and her presentation on AI governance in radiography.
Hello, my name is Dr. Christina Malamateanu, and I would like to present about our paper on AI governance in medical imaging. I'm an associate professor in radiography at City University of London and a director of the postgraduate program in radiography, as well as the module leader for the AI introductory module for radiographers. These are my conflicts of interest. So the objectives are to define AI governance, discuss the different aspects that entail AI governance based on our recent research, and highlight the importance of AI governance for AI adoption. There has been a lot of discussion recently about the need to regulate AI and to govern AI to ensure that we maximize the benefits, and we minimize the risks that arise from that. Both in the UK and the EU, there have been, with a few weeks of delay, significant announcements around agreeing on the AI Code of Conduct in the UK at Bletchley Park and the AI Act at the EU Parliament. The publications in the area of AI in the last decades have had an exponential increase, as you can see here. There were many publications around AI innovation. We do hope that in the coming years, these publications will be more about AI implementation. In radiology and medical imaging, the publications are actually at the top of the list, as you can see here below. Radiology only compares to general medicine and when it comes to AI publications. And as we know, research precedes clinical practice, so hopefully we will see many more implementation studies on radiology. More than 80% of the FDA submissions for AI devices by therapeutic areas were directed at radiology. AI impacts radiology and radiography in so many different ways. We identify here 5 areas: workflow and appointments, patient safety, image quality optimization, image interpretation, patient care. A recent one is also staff well-being. There are no studies for that, but given the need to optimize the workflows and organize the rotas based on employee profile, AI could be very useful in this area. Image interpretation holds a very large share when it comes to using AI as a decision support tool for radiologists and for those countries where radiographers also report images. But also there are all the other operational aspects as we have discussed here. It's a very nice paper by Professor Marianne Hardy and Dr. Hugh Harvey that outlines the roles of AI specifically in radiography beyond image interpretation. When it comes to enablers for AI implementation in healthcare, which is something we all want to achieve after the explosion of AI innovation, there are 4 areas we need to look at for enabling that. The clinical needs. Does AI really solve a real clinical problem? The technological infrastructure, digitization, connectivity, good quality data and security, and acceptability and trust. And in there's a huge role for education, governance, transparency, and evidence-based practice. And finally, funding for the new healthcare models. There's been a lot of discussion around what is the priority when it comes to AI implementation into radiography and medical imaging practice. We have written a non-academic paper by myself and Professor McKendy. And one of the key priorities is indeed governance and regulation to ensure that we use AI in the optimal way and we avoid any risky areas. Also, training, as we discussed, is important for that implementation. After the Professor Eric Toppel's review to prepare the digital future, we have run a UK-wide survey for radiographers, which has identified a huge gap in training. And this is similar to other professionals in the AI ecosystem in radiology. Recently, NHS Digital Academy have developed some seminal reports about understanding and developing healthcare workers' confidence in AI. Now, the main topic of today is more about clinical governance. Clinical governance is a system through which NHS organizations are accountable for continuously improving the quality of their services and safeguarding high standards of care by creating an environment in which excellence in clinical care will flourish. This was by Scully and Donaldson in 1998. There is not such a statement yet for AI governance. And governance is all about trust for all the key components of the AI ecosystem, for the developers, for the practitioners, for the researchers, for policymakers, for the patients, for the public. So we did a study to try and understand this space a bit better. The study that you have been discussing today, the field of AI governance is still largely developing, while today there is no consensus on AI governance as a framework. And there's an urgent need to propose such framework to maximize the AI system's benefits and mitigate any potential risks associated with its implementation. So we did this study. The aims were to create this conceptual framework for AI governance. The study was run by City University of London with some collaborators. We wanted to highlight the different elements of the framework and understand the impact of AI governance on AI adoption in medical imaging through multidisciplinary teams and initially in the UK context. We received funding from the Society and College of Radiographers CORIPS funds and ethics from City. We also had different primary and secondary investigators, and we worked with research fellows throughout. Our collaborators were multidisciplinary and also from different areas of practice, from academia, from clinical, from research, from industry. And we were fortunate to work with 𝐅𝐨𝐫𝐻 Health, Dr. Hugh Harvin and Mr. Mike Pongos as expert advisors, with Dr. Amrita Kumar and Dr. 𝐅𝐨𝐫𝐻 Malik as radiologists, Dr. Anna Barnes as medical physicist, with Dr. Tracy O'Regan from the Society and College of Radiographers and Eric Ascar from the Royal Marsden Hospital as the radiographer experts. We had a lot of input from the AI advisory group of the Society and College of Radiographers. I was the chair of that group at the time of that survey. And we also worked with an expert qualitative researcher, Dr. Lito Saliti, expert in focus groups and translations into practice. These were all our endorsing agencies. The study was called Black Box No More, Understanding Governance and Guiding Adoption of AI in Medical Imaging and Radiotherapy in the UK. The academic partners were City University of London, University College Cork in Ireland, and the policy partners were the College of Radiographers, the British Institute of Radiology, and the Institute of Physics and Engineering in Medicine, as well as 𝐅𝐨𝐫𝐻 Health as the industry consultancy partner. We did a scoping review. This is the article we are discussing more today, which was published in the British Journal of Radiology recently. We also did a survey, a UK-wide survey, which is currently submitted and under review. It takes a bit longer because the publishing times have increased massively after COVID-19, which was actually worked very well. The survey piloted and drafted through expert discussions, particularly focus group discussions with experts, which helped prepare the work for the survey. We took a lot of time to write the survey, a lot of time to pilot it and test it before we launched in the UK. And then we had selected interviews, which are currently being drafted into a paper. Lots of iterations of the different papers and the different data collection tools happened through regular research group meetings. Now, for the first paper, the scoping review, we have managed to find from the resulting publications through the search of the literature the following 7 pillars of AI governance as pillars of this conceptual AI governance framework. First one is validation and evaluation of AI tools as necessary to ensure they're properly regulated. Regulation, legislation, and ethics for the same reason, the work. AI auditing and quality assurance. You can call that perhaps post-market surveillance. The words don't really matter when it comes to functionality. AI research and innovation for constantly improving them. Training of staff and education, as we saw, is quite important for adoption, and the work hand in hand with governance for that reason, including public, patient, and practitioners to ensure the frameworks, the tools are all co-constructed, and very importantly, robust leadership and staff management to ensure that the frameworks don't stay as frameworks, they go down to the people who use them, and they are being discussed, evaluated, and perhaps amended, improved, as well as the same for the AI tools. So these are all the elements of AI governance. And furthermore, if we look into these 7 different areas in particular, you can see the different topics that garnered most of the interest from the analysis of the literature, published literature, peer-reviewed literature here. So when it comes to validation, we are considering things like external, internal. We're looking into the intended purpose of the medical devices, AI-enabled medical devices, the performance of each model, the clinical effectiveness, the interoperability, and the expected costs. When it comes to regulation, things like data protection, data privacy, confidentiality, informed consent, safety, accountability, trustworthiness, inclusivity, and transparency and explainability are important. When it comes to AI auditing and quality assurance, things like safety, pre- and post-market surveillance, accuracy, model bias, and clinical outcomes, clinical and technical performance monitoring, and quality of services. When it comes into research and innovation, prospective research is much more important than the retrospective. We have enough of retrospective studies, so we need to go into the prospective. Clinical academic partnerships are vital to ensure we get, authenticity in our studies. Accurate reporting of AI tools is necessary, and there are some frameworks out there like the Consort and Spirit AI guidelines, continuous improvement, and evidence-based knowledge. Training of staff, central to safe AI adoption, digital competencies, technique, and person-centeredness are vital. There are different professional body requirements now for that, like the college, like the HCPC for the radiographers, but for other also professions that will emerge. And staff confidence and competence is vital to ensure that they engage with the new technologies and they adopt them. Patient-public involvement, all users and stakeholders have to be involved because all opinions matter throughout the AI life cycle and not just at the end. There is a real consideration about usability and the user needs. There's co-production, co-design, expertise by those who have lived experiences, and better informed services are designed that way. And finally, when it comes to leadership, people have to be agile and adaptable because AI changes very fast. Multidisciplinary collaboration is necessary to ensure all voices are heard. There is an all hands on deck approach because this is an ecosystem. Diversity is vital in decision making. Change of culture is required, and stopping resistance to change as well, and teamwork. So this was like the vertical way to look at the 7 different pillars. But if we go into the horizontal way, we would perhaps organize this material we found into the paper into 4 different categories. One is clearly something about regulation and ethics, and they're not the same thing, because regulation is the things you do when everyone is watching, and ethics is the things you want to do when no one is watching. Nobody makes you follow that the ethics, but everyone wants to follow the AI regulation. Now we do have more about more graspable AI regulation after these recent governmental top meetings and summits. So for regulation, we have discussed all the different things about safety, accountability, privacy, data protection, GDPR, risk management. For ethics are different things like trustworthiness, things that are more difficult to measure and perhaps regulate, explainability, transparency, traceability, fairness, but all very important. And in the future, many of those things from ethics will pass over into regulation and we will require much harder evidence from those. The second area that governance is relating to is the validation. It's actually what you do before you use it, before you buy it, before you procure. And obviously the evaluation, does it work for you, and auditing. So this is more like a quality system and more like quality management. And it's quite important because it helps maximize the added value of AI. There's a big topic, there was a big topic about education research, pedagogy and research. And one is important research to continuously improve AI. And education is important to ensure everyone is on the same level. Everyone can contribute, everyone can acquire the language of AI. When it comes to stakeholders, and this is the final category that we have identified through this horizontal categorization of the themes, we need to ensure all the stakeholders are on board, both the experts by training and the experts by lived experience. So the latter are patient, public, and practitioner involvement. So patient, public involvement, and practitioners are the experts by training. And they should be there throughout the life cycle, from the conceptualization, so the innovation, the evaluation, the validation, evaluation, to ensure we have better informed services and tools grounded on real user needs. And of course, the leadership and staff management, including the introduction of AI champions to ensure clear guidance, teamwork, multidisciplinarity, diversity, and interprofessional collaboration within the AI ecosystem. One thing I would like to say, we did not include any discussion on purpose about reimbursement, economic analysis, or impact and costs, acknowledging this is vital for governance, but because there were not enough papers at the time we were doing our scoping review, we felt this should be kept out. Now, one thing I would like to do is go very quickly for you. You might not need that, but it feels important to say that we operate within a framework. There are different frameworks that are trying to describe, manage, govern AI that we have been very fortunate to have in the UK. So we don't say we have created the only framework. We just created a generic framework that can be customizable to individual practices in radiology and radiography. But we would like to also show what has come before that. So we have had the NICE Evidence Standard Framework 2018, recently reviewed for 2022. We also had a lovely publication from NHSX, the Buyer's Guide, which was excellent when it comes to practicalities for AI implementation, including some areas of governance and regulation. We had the MHRA software and AI as a medical device, publication roadmap. We also had this lovely website from the NHS AI and Digital Transformation Service for Health and Social Care, which is online and easily accessible, a step-by-step approach for developers, quite important for developers and adopters. There's a guidance list here, as you can see. This is the former Multi-Agency Advisory Service, or MAS. There have been different standards, but there is this British Standards Institute recent validation framework PS 3440, that received a lot of attention in the last 2-3 years, I would say. I was fortunate to be part of that team of innovators and industry and academia and policy and education and clinical practice. We worked together for about 2 years, between 2020 to 2022. And then we sent it out for public consultation. It was last year in December, not this year. And we have published in BMC Health and Care Informatics. You can find the paper here, which outlines the 18 steps and assessment criteria that people need to consider for validation of AI during their product's life cycle. I've also been fortunate to have this multi-society joint ethics report on AI from the European Society of Radiology, American College of Radiologists, RSNA, and many other societies at European and national level. It's mostly around ethics, but it includes some aspects of governance as well. There was also the guidance on AI practice, education, research, and partnerships from the Society and College of Radiographers. I was very fortunate to lead that group on the AI that was back then the working group at the College of Radiographers, to deliver that as a roadmap, as an initial thoughts shared with our colleagues in radiography to ensure we actually have some actions put in place, some priorities outlined for our colleagues who work in radiography. More recently, with the UK and European colleagues, we worked to produce this paper that outlines the massive importance of governance as well as AI education to ensure that we accelerate implementation and we set it in the right direction. And outlined these principles you can see here. There are 10 different principles around responsible AI. We didn't call it governance, we call it responsible AI, which came from a rapid review of the literature. Looking into the future, it's important to be involved and engage with AI regulation and governance. It's vital for adoption and for affirming AI's enabling role and not giving it bad publicity as we have seen recently, because it doesn't need that. We don't need that. We need it to work well for the benefit of our patients and for the benefit of the workforce. We need more partnerships, clinical, academic, industry, multidisciplinary ecosystem representation involving all key stakeholders, including patients as well. We also need contribution to AI governance, research, and applications in different contexts. We need to co-produce subject to specific regulation and standards for diagnosis, but also for the operational aspects of medical imaging too. Things like positioning of patients, planning of scans, workflow optimization, and patient safety. And we need to be learning more about governance. So there are many podcasts, courses. We run a very nice AI course for radiographers at City University of London every year during the World Radiography Week. It's for 4 days on campus, one after the other, and the last day is online. Very successful. Dr. Amrita Kumar, Dr. Rizwan Malik, they teach on that, and many other experts. It's 30 hours of intense teaching to learn the language and be part of that amazing revolution that we see in healthcare. And finally, well, what we hoped to do with that study, hopefully we did it, and there is more to come as well, is to create a comprehensive conceptual framework of AI governance as necessary for adoption. And as organizations calibrate the extent of human involvement in AI, it's also crucial to define what AI governance means for them. And this we would not answer. It will come probably, hopefully, from the second paper, the survey. This does not fit into a generic framework. It has to be customized for local contexts. A robust yet versatile AI governance framework is the means by which AI adoption can be accelerated and used responsibly. It is the foundation of sustainable AI growth. So when people ask and they have reservations around AI regulation and governance, whether this is a friend or a foe, I would say that if it's simple, user-friendly, and includes 360 feedback, then it promotes safety, efficiency, and efficacy. If it's complex, obscure, and out of context, then it can only propagate confusion, lack of engagement, and will curb innovation. Thank you so much for listening to me. There are more papers on the way. Please contact us to discuss further. Thank you very much for the opportunity, and I hope you have a productive meeting and day. Thank you so much. For any questions, you can always email me here at my city mail. And this is just a list of references, but you can find more on my ResearchGate account. Thank you so much.
Christina, thank you for the lovely discussion revolving around governance in radiography. I have to say, I align completely with your view. Clinical governance in the medical imaging field, if appropriately structured, can play a key role for many things, like ensuring patient safety, maintaining the diagnostic accuracy, and also upholding those ethical standards. As AI increasingly integrates into common radiological practices, I think establish a solid governance framework becomes substantially essential. Let me also echo what you said about the fact that as a community, we should be more probably involved and engaged with AI regulation and governance. And this is quite vital to maximize the benefits of this technology, while at the same time also decrease the potential risks. And this guides us to the final lecture of the event before meeting all the speakers at the round table. Before doing that, let me say thank you for everyone who popped a question in the Q&A. Samuel and I have been literally answering multiple questions since the beginning of the event. We have been floating between 250 to 300 attendees, but keep please asking questions, because some of them will be discussed during the round table, which will be the juicy part of the event. So get ready for that. In the meantime, next speaker, we are very honored to have here today with us Jan Begge. So Jan is the head of AI at GE Healthcare. What I believe is very interesting is that Jan's goal is to demystify AI in healthcare by simplifying concepts to aid AI integration into the daily work. Overall, Jan has over 15 years of experience in healthcare informatics, the medical imaging domain, and management. He also plays a key role in educating the younger generation about AI societal implications, aligning with his vision about AI enhancing rather than replacing the human touch in patient care. So Jan has kindly committed today to explain us why healthcare needs AI. So Jan, whenever you're ready, you can just share a screen and tell us a little bit more about the reasons why we need the implementation of this technology in healthcare. Thank you so much.
Thank you very much, Julian. Just give me a second to share my screen. Actually, I mean, great talk so far, and I'm a bit wondering what is left for me to talk about. But look, it's such a broad domain, and therefore, right, doing this live right now with you guys here has the beauty of, on one hand side, being able to like comment maybe to some of the things that have been said, but also adapting my talk accordingly to what already have been spoken about. So look, what I'm going to do is I'm sharing my screen and get started. And please let me know, Julian, if you can see my screen.
Are you sharing now the screen, yeah?
I think so, yes. Can you see it?
Not yet at the moment.
Okay, just give me a second, sorry.
Yes, take your time.
Oh, it seems like I need to close Chrome here for a sec. Sorry for this. Let me do this quickly. I'm back in a second.
And no problem, take all the time you need. I was just saying, in the meantime, we had like lots of questions. I don't know, Sam, if you want to jump in as well to discuss about the incredible number of questions that we had so far. I mean, if you pop on the chat box, you will see we've been literally replying to questions since from the very beginning. And this gave us the idea about, as I was saying at the beginning, the complexity of this topic. I think there are more questions than answers at the moment. What do you think, Sam? I mean, it seems definitely there are more questions than answers.
I agree 100%. We had around 50 questions just here on the event. We've been replying on LinkedIn and by email as well. So there's questions coming from all media platforms at this point. And some of them are quite tricky to answer, of course, because they involve reading articles and things like that. So I'm encouraging everyone to send an email to our email, which is info.everythingmri@gmail.com. If you have some questions that are more deep and they need a revision of articles and things like that, just email it to us so we can share with the speakers later on and get dedicated answers for those. But thank you so much for the engagement. It's been amazing. So I think Jan is already on the call, so let's jump into his conversation.
Perfect.
Yeah, thank you.
Julian, can you see my screen now?
Not yet. Can you see it, Sam?
No, it's still not online.
Sorry for this, gentlemen. There is no good webinar without some technical hiccups.
Absolutely.
So I was like,
exactly. And I have not been the easiest to work with in the preparation phase, so this is what happens then. So just give me a second.
sure, no problem.
I promise it's going to be some interesting stuff.
I'm sure it's
Not a
going to be
problem.
worth it. I'm sure it's going to be worth it, Jan.
I don't know if you agree, Sam, but one of the main questions that I've seen asked so far was about the fact that how AI is going to integrate with different MR parameters. Is it actually, someone was pointing out, what about the SAR? What about the image quality? What about the SNR? So a lot of questions about MRI and AI application, I have to say. So,
Yeah, I think the SAR level 1 is one of the questions that we got the most, and I'm interested to see what, for example, Bach has to say about it, and Doug maybe. So let's wait for the roundtable, but I'm really keen to hear from our speakers about that one, because it's been the question that most of the people are asking, because apparently a lot of people that use AI experience difficulties with SAR levels, even at 1.5 Teslas, which is something that I wasn't expecting to hear from.
I've seen also a lot of people pointing out the fact that the number of patients that they have to scan now apparently has increased significantly. And this is another thing, to be honest, we'll need to point it out. Interestingly, I haven't seen many questions of people asking, will AI replace my occupation? Will I replace my job profile? So that was one of my expected questions, which is good. It means we are not kind of probably fearing AI that too much, but we are recognizing the impact. If someone noticed that obviously we need to scan like 2 patients in like 20 minutes rather than before we were scanning 1, obviously will have a massive impact on our workflow. It might not replace our profession, but still. So we need to address positive and negatives as well. What do you think?
Absolutely, yeah. Jan, I believe you're ready now.
Just, yeah, I think in a minute. Sorry for this.
Yeah,
I'm
no
still
worries.
trying to figure out why it's not working. Yeah.
Good. Sorry, Julian, I didn't want to go on because I want to save the, as you said, the juicy details for the roundtable.
Yes, absolutely, absolutely.
Best place to discuss these things. Otherwise, we'll be talking to each other for a long time.
Yeah,
Another
exactly.
podcast, the live one. I would say. And we have loads of interesting questions. I wrote down the names as well, so I will bring those questions to you while you run the roundtable with the guests. So I'll mention the questions by name. So the persons that actually ask the question, I'll mention them and give the question to the speakers in general, or if they dedicated the question to one of the speakers, I'll ask them straightforward. So I'll try to ask as many questions as possible, but we had, as I said, around 50 questions just here. So I'll try to ask some of them. We answer a lot of them as well ourselves, as we said, and some of them will be answered by email later on. But I think the most important ones are the ones that people ask quite often. And I was also surprised where you said that nobody asked that one, if we're going to be replaced or not. But I'm keen to see what our speakers have to say about that too.
Absolutely. While Jan gets ready, I would just take this spot also to remind everyone. I know you wanted to do it later, but I think this might be a good opportunity. We have a lovely podcast that we run almost monthly. So if any of you wants to know more about AI, but MRI in general, we usually talk about wide range of things about MRI. So you just need to tune in to the Everything MRI podcast available on Spotify and YouTube. So I think AI is probably one of those topics we haven't covered much yet. I think it seems like there is a lot of juice, to be honest, for a massive discussion.
Sorry, I was just reading a question as well about the Tesla wars in terms of the 1.5s, 3 Teslas, and if AI is going to take over the Tesla Wars topics, because we know that the high Teslas, the low Teslas, it's something that we've been talking quite a lot within the MRI community.
Yeah.
So it's an interesting question, actually, because I think AI is stealing the show at this point. So we'll see.
Very interesting to hear what Bach thinks about this as well, to be honest. Since he's an old-fashioned radiographer who started with a 0.2 Tesla, probably Doug as well, maybe.
I can see Doug is already excited about the SAR levels. He just texted us. He's keen to jump into the roundtable. So this question will be definitely for Doug. The SAR levels at different scanners with AI. I think it's going to be interesting. I'm very interested to hear as well, because we don't have AI in one of our scanners, and I want to understand exactly what is the issue when we use AI to make the scanners quicker, but at the end we make them longer because we have SAR conflicts. So very, very interesting discussion ahead, I would say.
Absolutely.
So, gentlemen, for some reason I don't get slides to work, but look, what I think what I can do at least is talking through my content, which should be fine as well. It's just some visuals to support it, but if it doesn't work, that's hopefully okay as well. Look, what I would like to do is, before I actually kick off, and again, sorry for the delay and the issues here. I mean, the previous speakers I said have said pretty much everything. I was wondering what to speak about, Julian and Sam. But look, one comment to Bach, and maybe we can in the panel talk about this a bit later. I think you mentioned things like there will be no radiographer, right, who does not know AI in the future. So everybody needs to know. I think I would even go a step further and say, in the future, we'll only have radiographers or MRI techs, for instance, who understand the basics of AI and leverage this technology in their daily work, right? So I think this is really the future we are heading to. What I'd like to do is I would like to broaden the conversation a little bit, zoom out a bit, and actually start with a couple of interesting facts about, right, my point in my presentation, which was called Healthcare Needs AI. Look, first of all, today it just takes 72 days to double all medical data, right? And think about this. In 2010, it was 3.5 years to double all medical data or medical information out there. Now it's just 72 days, which is massive. Also, picture that 30% of the world's data is somehow healthcare related, which is also a massive number. It just takes, or every 22 seconds, actually, a new medical article is published. I mean, Christina just previously talked about a lot of great publications and papers, right? But when you broaden this and you just think about every kind of healthcare related article out there, every 26 seconds. For instance, right, switching a little bit the domain, but for a dermatologist, for instance, they could read 3,900 scientific publications each and every year. When we look into, for instance, the knowledge a general practitioner would need to have to keep up with primary care literature, they would need to read for 21 hours each and every day, right? Something which is just impossible to do. Right, Amrita talked about mammography a lot. When you, and probably you know this, right, a mammography image can go easily up to 1 gigabyte in size and contains lots of information. So what I'm saying here with all those facts is there's a huge data explosion in all facets of our lives and also in healthcare. In radiology, for instance, right, like a radiologist at a 12-hour shift today is looking at about 50,000 images compared to just 500 about 15 years ago. Yeah, so massive amounts to data and information we have to deal with. Actually, there is, right on the flip side, there is this interesting fact that there are only 3% of the healthcare data produced that is actually used to generate insights, right? 97% of the data we produce around health is just really untouched, unharnessed, unleveraged, and often, right, especially for hospitals, when they produce it, it's just like cost because it has to be stored, it has to be archived, but it's not really impacting somehow healthcare overall. Another topic I want to point out, beside what I just mentioned, right, which I would call like the data explosion we have to deal with, we have to manage. Another interesting thing is, right, the overall theme of medical errors. And when you compare, for instance, and maybe it's not a fair comparison, but when you, for a second, compare like healthcare with the flight industry, right, there is in let's say in flight and airplanes, there is a 1 in a million chance of a person being harmed while traveling by a plane. Compared to the healthcare industry, there is a 1 in 300 chance of a patient being harmed during healthcare. Yeah, so what I'm saying here also, there's lots to be done as well in terms of quality and reducing medical errors and so on. Actually, in Europe, it's estimated that up to 163,000 patients die every year due to medical errors, which is, for instance, the size of Venice in Italy or Toulouse in France, yeah, the population of those cities. Another pressing problem, I think, around the world, but especially right in the more developed economies. In the UK, it's a pressing problem, which I think everybody's aware of: workforce shortage. Yeah. Today, I mean, at a global level, right, across healthcare overall in medicine, there's a shortage of 7 million healthcare professionals, and the WHO expects this number to increase, and in 2030 it will be around 10 million. Right, so it's a massive problem we have to somehow manage and deal with. And look, what I'm saying is that I mean, we have those technologies, right? Digital capabilities, including machine learning and AI, and they will not solve those problems, but hopefully they can contribute to kind of soften those problems a little bit. Right, I just talked about this workforce shortage. Just maybe one of my last numbers is also to just mention that it's expected that in 2050, we will the first time have more people aged 60 or above than children under 15, right? So in addition to this existing workforce shortage, we also have this, as you know very well, I guess, this aging population, which comes with the rise of chronic disease, for instance, which adds even more pressure onto our already like stretched healthcare systems. So look, I wanted to point out those kind of big themes, and there are many more. I didn't even talk about like cost of healthcare, which in many economies is skyrocketing. I didn't talk about access to healthcare, which in some parts of the world is also a huge issue. But I tried to just point out a couple of things where we believe the implementation of digital technologies and AI can really make an impact. So look, I wanted to show you some slides, but again, for whatever reason, technical issues here, it didn't work well. I don't want to talk much about technology, but I wanted to talk a little bit about interesting use cases. And as we already have heard a lot from Doug and Beck about MRI, and from Amrita about mammography, and Christina like an overall kind of research and scientific kind of talk. I thought maybe I'd pick a couple of interesting use cases from across healthcare, right, from different stages of the patient in the care journey. Some use cases maybe that also support like clinicians and healthcare professionals. And the first thing I wanted to share is a doctor in the US who has been using, right, something I think that was not mentioned, which is very surprising to me in this session today. He was using ChatGPT immediately when it came out in November 2022 and started using it, helping him with more an administrative burden he had to deal with. Right, US-based, he's a rheumatologist. I was in touch with him early in 2023, and he showed how he is using now ChatGPT to help with insurance denials. Right, so basically kind of administrative letters back and forth to the insurance to make sure his patients get those examinations that are required or therapy approved. Yeah, very useful. I mean, what is important, right? Don't enter patient details in those letters or whatever you use it for, but it can really help kind of streamlining administrative tasks. This is what he has showed me, and this was quite an impressive use case. Another example, also early in 2023, right? ChatGPT was just out. I was in touch with a 19-year-old student at Stanford who connected ChatGPT to the health app on his iPhone, right? And now we're able to have like a conversation with his own health and fitness history. And what we have seen since early 2023, I mean, a lot of those wearables like fitness trackers, smartwatches have now implemented those capabilities. And you can now have like a conversation, right, about your sleep, about your fitness, about your overall health. You can get guidance how this can be improved and so on and so forth. I think this is a huge step forward already. Look, another thing where I believe, right, this kind of new generation of AI is going to make a massive impact is in the field of supporting patients more on the emotional side. Yeah. And what I wanted to show you is just like the user interface of a great chatbot that has been put together, leveraging on one hand side, right, this great technology of generative AI plus the knowledge and experience of a breast cancer survivor. And right, this tool has been built. It's called Ask Ellen, to really help cancer patients to go through their journey. And this chatbot is available 24/7. It's for free, and it's really built to kind of emotionally support cancer patients throughout their journey. And what I've seen in conversations with people who have used it, what I've seen from the team that built it, it seems like this is also a fantastic use case going forward to support those who deal with issues in their health, such as cancer. Look, another short video I wanted to show you, but look, I can also briefly talk about it, was a startup company out of Lithuania. And they showed me mid of 2023, basically how they took an entire patient record, right? And I'm sure you know this, which consists of, I don't know, handwritten notes, patient history, lab results and tables, other reports, structured, unstructured. And their generative AI solution was able to kind of bring all this information of this such an extensive patient record together into a one-page summary about the patient. And when you think about this, right, and when you think about clinicians who want to get a short kind of or quick overview about a specific patient, about their history, about their current status, I think this is another fantastic use case, which I believe in the future is really possible. What that startup showed me almost a year ago, I don't know what was really true at that point in time, but we are getting there. The technology is there, and it's just a matter of time when those kind of capabilities will be available in healthcare settings. One thing I want to point out is, and I come to this in a second again, and Christina mentioned this as well, we're in a highly regulated industry, right, for a reason. We want to make sure that all those technologies we implement in healthcare do not harm our patients, right? We want to make a positive impact. And therefore, all those AI technologies, I mean, similar to other, right, technologies and devices we use in healthcare, we need to make sure they are validated, they can be trusted, and they work well and do not harm patients, right? So this is always the overall North Star, which we have to follow. And therefore, maybe adoption of AI in healthcare overall is a bit slower compared to other industries. But again, right, this is okay. This is for a reason. Look, another field where I believe healthcare AI can be very interesting, right, and talking about now own experiences in my family, is in doctor-patient interactions. Yeah, I mean, what I've often experienced, also very recently with someone in my family, is that when you have an appointment, right, at a practice or in a hospital, when you have a doctor appointment for diagnosis or therapy, often the clinician, the doctor who's speaking with you, you have a meeting with, hides behind screen, right? And they do this because they have to enter information into the EMR or EHR system. They have to get information out, and they focus usually much more on the screen in front of them instead of focusing on the patient, right? And hopefully AI will also solve this problem to some extent by, imagine to remove this screen, right? And have like an ambient AI around you that is kind of following the conversation, records the relevant points, documents them in the EMR, for instance, so that, right, really this person-to-person relationship and conversation we can really come back to this, which I believe is very important. Switching gears a little bit, and right, Christina also talked about radiology as really the leading medical domain when it comes to the adoption of healthcare AI. This is true. This is what we see as well. But there are other, like primarily imaging domains, which are following, right? Thinking about pathology, dermatology, ophthalmology, for instance, and other domains. But again, it's still the fact that radiology is quite ahead. Also, when you look into, for instance, the FDA clearances of AI or machine learning enabled medical devices, radiology is really at the forefront. And with this, of course, also those big players and vendors in the radiology domain. Look, I wanted to pick a couple of interesting, more like radiology specific use cases. And one of the things, and again, right, I mean, I know this is a very MRI focused audience, but I thought maybe some kind of other examples are also interesting. For instance, one I wanted to talk about is on a mobile X-ray machine, right? I think you know these devices, you have seen them, right? They are very flexible and mobile in a hospital setting. For instance, they can be used in the emergency room, at the patient's bedside, in the ward, to get, for instance, a chest X-ray very quickly and comfortably as well. What we have been doing there already a couple of years back is putting AI into the machine to help, for instance, with detecting critical conditions, right? So what the device can do now is it detects and informs the user about, for instance, the likelihood of a so-called pneumothorax, right? A collapsed lung. And this is something that is, I mean, when the radiologist is around, that can easily be detected on the image. But for an occasion where there is no radiologist, it's good to know this to be able to act quickly. Yeah. Also, what AI does on those mobile X-rays machine more and more is it helps with like quality things, right? Making sure the image has the right quality and informs the user if maybe you need to retake an image, right? Or it helps with like positioning of endotracheal tubes, for instance, and so on. So great use cases in there on what I would call on-device AI. Look, another use case, which, and Amrita touched ultrasound very briefly in her talk, focusing on mammography. But ultrasound is a super interesting space for AI use cases as well. And I wanted to point out one specifically because ultrasound, in comparison to, for instance, MRI, is different because it's, on the one hand side, very flexible. I mean, those devices are very small, even handheld with no cable anymore today. You can do an ultrasound scan everywhere, right? In MRI, you have to do it in your kind of MRI kind of practice or department or setup. You are not that flexible. And also MRI scans are pretty standardized, right? Maybe you disagree, but compared to ultrasound, it is definitely very standardized. Ultrasound is incredibly dependent on the operator, right? On their experience and know-how, how to move the probe on the patient's body to get to like high quality medical images. So we have now put AI into some of our, right, and it's just the first steps, putting AI into our ultrasound machines. And the first use case was specifically for cardiac ultrasound. And now basically the ultrasound device tells you how to move the probe on the patient's body to get to high quality, usable medical images. Which I think is a fantastic use case. And right, if we can develop this further, eventually we could even, let's say we could democratize ultrasound and bring it really to those people who need it the most, but where really expertise and know-how is lacking. I think Doug at the beginning of the session today talked about air recon, right? A great technology in MRI. We move forward in all this space of deep learning in MRI, and just want to point out one new technology we just brought to the market recently. It's called Sonic DL, which helps with cardiac imaging and really brings down those images to like single heartbeat functional imaging. Right, breath hold free, which is very important in those cases. I mean, huge impact to the patient experience. Also, what we have seen very interestingly is that there's a lot of effort, right, across vendors to put AI also into like post-processing capabilities, meaning you have acquired the images and after that you want to do some more post-processing with it. And here as well, right, especially in CT, for instance, we have seen massive improvements in terms of segmentation, for instance, of organs. All this is much faster and much more accurate than just a couple of years back. Yeah, so huge improvements there, and I think this is just really at the start where we are. Also, we see more and more use of AI. I mean, we do this as well in some of our technologies, for instance, in computer tomography. AI helps the radiographer or the tech, for instance, positioning the patient on the table, right? So AI supported auto positioning is something that is more and more common and is coming to more and more of the modern computer tomography and MRI devices. Look, I think it was Amrita who mentioned, right, this term autonomous AI. And yes, this is something where, right, I think it's very early to talk about those kind of things, but it's interesting, right, and also responsible to think about this, right, especially in the fact that, right, we have this massive issue with workforce shortage. So what are use cases? What are maybe administrative processes that can be eventually, right, kind of fully automated with AI or with other capabilities and technologies? And there is just one interesting startup company which I wanted to mention to you. It's called Oxipit. I think they're also based somewhere in, I don't remember, but in Eastern Europe. And they have brought out a CE mark product. So it's basically commercially available in the European Union for what they call autonomous chest X-ray triage, right? So basically they rule out all chest X-ray out of the reporting list of the radiologists that are normal. Yeah? And I think if this works well, and I think there are now pilot studies that they are running, this can be a huge time saver, right? Because I think quite a lot of chest X-rays are done still in like regular radiology departments all across the world. And if you can just kind of remove or move down those that are very likely normal, I think you can save a lot of time actually. Look, another example I just wanted to mention is also more like, again, administrative processes, moving away a bit from the imaging side of things, but what I would call missed care opportunities, right? I mean, I'm sure you have experienced this yourself if you're an MRI technician, right? A patient has an appointment but doesn't show up. And this often is just a huge kind of issue because you cannot quickly, especially in MRI with all the coils and so on, right? You cannot quickly enough readjust. You cannot kind of often bring back the next patient earlier, bring in the next patient earlier. So it's a lot of issue in terms of scheduling, in terms of capacity, because your room is specifically prepared and so on. It's also, I mean, yeah, it's also from an economic standpoint, not something good. So it would be great if you could kind of predict, yeah, if there is a so-called missed care opportunity, right? Or a patient is likely to miss an appointment for an MRI scan, for example. Yeah, and there are now predictive technologies out there who can do this. We do a research partnership on this right now, where we, for instance, take into account a variety of different factors, such as, I don't know, weather data, traffic information, EMR data of the patient, and so on, to figure out, okay, is there a likelihood for the patient to not be there at the time of the appointment? And then if you notice upfront, right, I mean, obviously you can do something about it. You can either give a call or text a patient and just send a reminder that there is this appointment and the radiology department or the MRI team is expecting the patient to be there. Yeah, so just another kind of interesting example use case I wanted to share with you. So all the things we have been talking about so far, right? All the use cases I shared, all the use cases the previous speakers today have talked about are what is called narrow AI, right? I mean, AI technologies, AI models that have been built for very specific narrow use cases, right? Things like detecting a pneumothorax, detecting lung nodules, whatever, Yeah. And then today, for instance, when you are a great AI startup, you build such an AI model, and then you want to move to the next anatomy or pathology, right, or modality. You basically start your entire AI development process from scratch, defining what you want to do, collecting the data, building your model, test it, validate it, and so on and so forth. Yeah, and this is something which is a very lengthy and very costly process, especially thinking then also on including the regulatory approval that is required. And this is another reason why adoption of AI overall is that slow, because building those products is relatively difficult and slow and takes time and is expensive. So therefore, things take time in healthcare. And look, there is like some light at the end of the tunnel, I would say, right now, or at least some new kind of technology or new capabilities that will eventually help us in the future to speed up AI development overall. And this is what I would call under the theme of foundation models, right? And again, unfortunately, I cannot share my slide here for whatever reason, but when you just Google foundation models, you find a lot of information about this. This is like the new kid on the block. And this is something which will enable us, right, at least we expect, to speed up AI development significantly, because you don't need to start building from scratch, right? You can leverage your pool of data. You can leverage like the model you have built already, and then just, I simplify, fine tune based on your new use case, which should really enable us to be much, much faster in AI development going forward. This is something very interesting. Right, those models can generalize much more. Right, we move away from this bit, or what I call narrow AI, to a kind of broader use cases. They are very flexible, and this is really going to be the future. To share one or two example use cases we are working on more, like in research settings, for instance, right, with foundation models and generative AI, right. So this new generation of artificial intelligence is in radiology. How to provide those radiology reports. Yeah, you know this better than I know it, but the MRI report is kind of is your business card, right, to the referring physician or to the patient, and they are often very complex. Yeah, in a way, they are written in a way that are, for instance, for the patient, very hard to understand and very hard to interpret. So why not having, beside this great MRI report the radiologist produces, why not having one that has been translated into layman terms for the patient? Or why not one that has been kind of adjusted based on the needs of information of a surgeon? Yeah. So this is an example use case we are working on, also in computed tomography, for instance, protocoling. Yeah, so which scan protocols to be chosen? This is also something I think in the future that has huge potential for automation, or at least providing suggestions of what protocol you can use based on a variety of different parameters. But look, the most interesting use case for me in this context of foundation models is that this technology will very likely open the door to what I call multimodal AI. Yeah? Today, the AI tools we have, right, that are out there in some of the radiology practices and departments, they're not just narrow AI, they are also unimodal, in the sense of they just kind of use one type of data for inferencing, yeah, and to get like a result. But when you think about how your radiologists work, right, how a clinician works, their entire kind of reporting approach is inherently multimodal. Yeah, they take into account not just the images they see in front of them on the screen, but also patient history, the latest lab results, for instance, and other contextual information. Yeah, and this is where we need to get to with AI, so that an AI model can consume a variety of context-relevant data, right? Be it images, text, whatever, yeah, and then get to like predictions or conclusions out of this multimodal data. So this is very exciting, and this is very likely to be the future. So I want to point out one more thing before I come to the end here. And I mean, Christina mentioned this already, but it is very important, right, in all things we do in healthcare AI, is that we do it in a responsible manner. Yeah? So we need to be careful. We need to think about things like ethical design of those products. We need to think about, right, this broad term of AI explainability, right? As a clinician, as a diagnostician, at least to some extent, I want to figure out, I want to know how an AI algorithm came to a specific conclusion. For instance, we need to think about trustworthiness of those technologies, right? I mean, they need to be robust, they need to be fair, right? Bias is always a big topic in AI overall. And last but not least, and Christina mentioned this as well, you can have fantastic AI capabilities, but if you are not able to integrate them deeply and seamlessly into your existing workflows, they are pretty much useless, right? So interoperability in this overall context is also something very, very important. Look, I want to close with a few suggestions. First of all, and I recommend this really to everyone here on the call, familiarize yourself with AI, right? I'm not saying you should become a data scientist or AI engineer yourself, but try to figure out learn about the basics of AI, yeah, and figure out for yourself, hey, how could AI technologies that I eventually use in my personal life, how could it help also in my workflows at work, yeah? And I really engage you to have conversations with your team, with your department in your practice about the usage of AI, about the adoption or avoidance of AI technologies, right? And really get into this topic because it's here, right? It's staying, it's coming even more, and we all should be prepared, right? Coming back to what Buck said earlier, radiographers with AI will be there in the future, and the others will very likely be not. If you want, right? I mean, just one last thing. There is, and Christina mentioned also a couple of great training opportunities. If you Google for Hello AI Professional, you'll find a website which we are providing with, right, together with a variety of partners. Hello AI is a basic education program for healthcare professionals to really understand the fundamentals, the basics of AI. And if you're interested in this, have a look to this website. There are plenty of great resources out there. But again, I really encourage you to look into that space and at least understand the key terms, right? What is deep learning? What is this black box? And so on and so forth. I think everybody of us should know about this and should really, again, start thinking about use cases. And look, with this, I'm going to stop here my technically difficult presentation. Thank you very much.
Thank you, and thank you so much. I have to say that despite the technical issue, you managed perfectly to get the point why healthcare needs AI with a lot of beautiful examples, I have to say. So I love the fact that you pointed out the discussion on the different presentations. One thing I really say, oh my God, yeah, we are definitely it is the data explosion. When you mentioned the data explosion, and I want to echo what you said before, is that in literature we never seen such an amount of research paper like the early days. So how are we expecting that us as healthcare professionals, doctors, are absorbing all this knowledge at this rate? So this is a very interesting point, as you mentioned. So we definitely need to rely on something else on it. And what else? Oh, you also mentioned about ChatGPT, that very nice example about kind of like make the paperwork process a little bit more smooth for that doctor. I mean, there are examples every day of even radiologists like relying a little bit on ChatGPT to get a sort of like pre-format report. Obviously, it will need to be assessed for the quality. But yeah, I mean, these are all examples how we are using technology at the moment. And then also the last thing, and then I will pass the word to Samuel, wants to add something on top of that. You mentioned that beautiful example about AI supporting the patient from the emotional perspective. And to be honest, this is something I always like. I have to say, when people will ask me, "Oh, do you think we will be replaced? Our profession will be replaced?" I always say, "Well, it will be very difficult that a machine, will be able to give the same emotional, let's say, approach from like the human being." And then you reported this example from a machine where a robot was actually helping the patient from an emotional perspective. So that shake me a little bit and remain a little bit, oh wow, so we definitely reach already this level. So let me just pass the word to Samuel. Samuel, do you want to add anything?
No, just a quick question for Jan, because a lot of people on the questions are asking if it's possible for you to share the slides later on, because they really see what you were presenting. They are really interested to see your slides as well. So later on, we can send it to them if possible.
Perfect. Amazing. I want to start from here, actually, Jan. I'm gonna ask all the speakers, if possible, to join us back for the roundtable, because I think you gave us a lot of assist to start our group discussion, and we have a lot of questions in the Q&A box that we're going to try to address all together. So Doug, Bach, and Marita, feel free to join us whenever you're ready. And Jan, do you want to start maybe to answer this potential question about the fact, do you think that in the future, and I mean, you already made clear that our profession is going to change at some point due to the AI integration. Do you think we will be at some point replaced completely? I know it's a little bit a very broad question, but this is one of the fear that many radiographers, sometimes even radiologists, have about this.
No, look, I don't think so at all, right? I think the value of healthcare professionals will just increase. And look, I think let me start with the radiologist, for instance, and Amrita, maybe you disagree, but I think, right, directionally, maybe the radiologist role as it is today will change into something what I would call like a technically supported diagnostician fusing multi-domain insights. Yeah, which basically means, okay, maybe we take care of, or radiologists take care of other imaging domains, right? I mean, pathology and radiology, there is like a natural fit somehow, right? And technology-wise, maybe there is a path towards this. And really becoming the consultant for like the clinicians and the overall kind of multidisciplinary clinical team to kind of educate and provide insights and information about disease state and give recommendations about the future care pathway. I see Amrita's hand up.
Amrita, go ahead, please.
No, Jan, I completely agree with you. I suppose I get asked a lot, will my job be replaced, whether I'm a radiographer or a radiologist? And the reality is that we're not sort of a unidimensional caregiver. We provide multiple services, whether we are radiographers or radiologists. We have admin-related support functions, we have clinical, we have patient-facing, we have procedural. So my belief is that some of the upcoming AI technologies that exist even today will remove the burden of some of the administrative works, which we will be able to offload, thereby creating some efficiencies, because we are all very overstretched. So that if, as a clinician, there are certain efficiencies with triaging, clearly normal things away so that we can reprioritize abnormal things first, so that we can affect immediate patient management from there. There's a huge role to play. If you're a radiographer, if there are certain AIs available that can either reduce the dosage of certain contrasts for PET CT or actually enhance an image with reduced scanning time, but with a similar quality, those things will really improve efficiency. My overall feeling is that the people who are going to be replaced in the future are those who don't use AI altogether, but it's going to be a synergistic, augmented, sort of combined role of the provider with the AI, irrespective of which clinical pathway, versus somebody who's not employing any degree of AI at all.
Yeah. And Amrita, if I may, right, I mean, thinking about radiographers or MRI techs, I mean, you are the ones producing those images, right? And you know much more than I know that MRI, there's always safety concerns and we need to be careful, and somebody needs, right, to take care of the patient during the examination, prior to that and after that. And therefore, I don't see radiographers disappearing, but maybe to kind of put in like one kind of interesting thought is, you all know much better than I know that the visible MRI image, right, is like a post-processed image, right? There is this case-based image which contains much more information than the visible image. So an interesting question is, will we need visible MRI images in a fully AI-powered future, or will AI just read the case base and we then just get a textual report? And I mean, just saying something controversial here.
I never thought about this perspective, and I have to say now we have even more juice to add on top. Sam, do you want to add anything? Oh, sorry. Yeah, I think Sam and Rita then.
Yeah, just on what Amrita was saying, there was a question that was basically AI is taking over by automating jobs that only require cognitive skills, exactly what you're saying. Do you see tasks that are only motor or social skills being taken over by AI in the future as well, or will always be just the cognitive kind of tasks there? It's actually going on nowadays.
I mean, when you say social skills, I assume for me that would be patient facing, and there's no task that can remove the sort of personalized interaction that you have when you patient face, because I mean, you can never say never. I'm sure, you know, I don't know what the evolution of tech will be in the next 50 to 100 years, but in the immediate, say, 5 to 10 years period, we are so far away from that. Right now, we're trying to, in my current role, I see multiple use cases, but actually, even ahead of the use cases, actually, we're quite simplistic in that right now, we're actually trying to show that whatever tech is coming in, how do we actually implement it into the real clinical pathway? And then once you implement it, you know exactly which points to collect data, and then how you actually look at the return on investment, because right now there's a huge focus on creating the business cases for healthcare providers to buy these technologies. And for that, you need to look at the metrics that you're going to, you know, either improve patient outcomes or introduce efficiency or patient or clinician satisfaction, or eventually financial returns. But that, in my opinion, will come more with autonomous role as we step up.
I also had something to add for what Jan was saying, because there's actually a company that's called Synthetic, something like that. And you were talking about case base and not even the need to have an image. We could have a report straight away. What this company is doing, basically, they require MRI pictures and they transform them into CT images straight away. So I'll put a thought out there. I don't know if you want to build up on that, but I believe in the future, we won't need X-ray, ultrasound, MR, CT. We'll have one modality and the patient jumps in and we have everything we need straight out of the box. So what's your thoughts on that for all the panel, of course?
If I may, I mean, synthetic data, right? This is a very interesting and evolving field, especially for AI development, right? I mean, one of the issues compared to other industries we have in healthcare is the fact that we don't have enough data, right? And especially those AI vendors don't have enough data. I mean, healthcare institutions, as I said, they sit on top of massive amounts of data, but usually vendors don't have easy access to that, right? Vendors need diverse, high quality sets of data. And one kind of way to kind of fill the data gap, which is evolving more and more, is synthetic data. And this also includes things like transforming a specific modality image into something different, right? Or changing just the impression of the image, changing what is seen on the image, right? Is it benign or not? So this is an evolving field. Look, just, and I stopped talking. I know I talk way too much. Sam, just one more thing. I have, in the chat, I have added a link, right? In case you want to share it. This is an example of more mammography, right? Of the future, how we see the future of healthcare or medical imaging. And it shows very well how important the role of the tech of the radiographer will be in the future. So thank you.
Just want to add something. Thank you, Jan. That was lovely. And I think the future links, I have to say, seems very, very interesting. Now, I want to involve a little bit the two radiographers over there, which seemed like very silent, but I know they have a lot to say. And there are a lot of questions for them, actually, because when you were discussing your presentation, I mean, the chat box was like on fire, especially of people saying, and I quote, I can give you a couple of messages here. Someone was saying, since the deep learning was integrated, all we got was more patients. The scan time was reduced, which led management to reduce the slot time. Another member of the audience basically said the same thing. First thing management did was to reduce the appointment time of some of the scans in at least 5 minutes. But unfortunately, some of the sequences increased too much due to the SAR, and when you have delay for the SAR to come down, and he's talking about a 3 Tesla scanner. So obviously, Jan was pointing out about the fact of the backlog, the waiting list. So this seems like a physiological pathway to kind of reduce a little bit the waiting times. But what about the radiographers? What's happening with the radiographers? So what's your expectation? Well, how do you see the future to come with this technology? Let's start with Doug. Maybe you spoke first, and then we got Bach immediately after.
Yeah, Doug, you can maybe start with the SAR level question. I think Julian.
Yes, that favorite 3-letter word, right? So SAR, yeah. I mean, just without AI, we fight SAR every day. If it's 1.5, 3T, now we're experiencing 4T, 7T. I was always taught, I'm very old school. You don't run all your fast spin echoes at the same time concurrently. You kind of break them up a little bit. That will help with the SAR weightings. Adjusting your parameters. I'm a big trade-off guy. Even though everything's set up, there's ways that you can go into the scanner and help with that SAR. Adding low SAR on your scans has helped me in the past, especially getting up into, especially 3T. Let's talk 3T right now. Running 3D gradients. I know that's been a big play. Dixon is having a big it's imploding right now. A lot of the radiologists are coming on board with Dixon. That helps with SAR tremendously. Adjusting your shim. I know when we get up, I know we're discussing 3T, but when we get up to 4T and 7T, we need to think about adjusting our shim, especially when we get up to the 7T. I know it's all research now, but in the next couple of years, it's going to be widely used clinically. So, if in a nutshell, trade-offs. Yeah, if you're scanning, at 3 millimeter by 3 millimeter, maybe you want to bump that up a little bit. And again, that's that relationship that you need to build with the radiologist as well. If you're finding out that you're having SAR levels and it's causing a havoc, you're running behind, you're 30 minutes behind, 2 hours behind, whatever, that's where you and the radiologist need to have that talk and say, hey, this is what's going on. Can we adjust some of these levels so we can control the SAR? Because we don't want to cook the patients. We're not in the business of cooking patients. We don't want patients coming out of the scanner with their gown soaking wet. That's not why we're here. But again, I would love to hear from Bach also. Trade-offs. Trade-offs is a big thing for me.
Thank you, Doug. Lovely also that you mentioned the 7T, because we have just seen the past few days the images coming from the 11.4T of the brain.
Yes.
So this is very interesting. So I might wonder what it might happen with the SAR in there. But I just want to leave some space to Bach, our MRI guru. Bach, what do you think about this? What are your thoughts?
Well, I think a lot of people are misunderstanding about the AI. Firstly, I just want to mention that back in the days, before my time, before your time, Julian and Samuel, I think in the time of Doug, because you have so long experience, you took one T2 sequence, which takes around 20 minutes, right? Yeah.
Yes.
Big slice thickness, took forever. There was no time to do a rescan because, it took too long. And then parallel imaging came around, right? Parallel imaging came around, cut the scan time. And I'm not sure if back then people are complaining about, I have to work much more now, a lot of more patients. I'm not sure about that. But currently now we're moving into a new era, which is AI. So it's probably the same now. The questions now are as back in the days with the parallel imaging. How can you cut the scan time so much with parallel imaging? But now how can you cut the scan time even more with AI? And I see in the questions here that people are asking, do we have to go courses, different courses about AI? Of course not. AI in your sequences, like I mentioned, is a tool. It's an actual tool you have under your sleeve. You can optimize. So even though AI is there on your scanner, you have to know the basic stuff. You have to optimize with the matrix, with the TI, TR, everything like that. So I just think that AI is a useful tool, of course, which I also presented in my presentation. But use it with care. Okay, if you use it like the maximum, you get plastic images, which is no good. And I also see it in the comments. Some people are writing, "Oh, we get some artifacts, which is mimic, which is not real." Of course, you are using it too hard. So you need to find with your radiologist the breaking point. And even though the vendors are trying to cut off where you cannot overrun the sequences, but you need to be careful. You need to think differently. So after I got the AI for around 1.5 years ago, of course, I need to think a little bit differently. The scan goes faster. A lot of people asking me questions about, oh, I have to do much more now. But that's just a true thing, because what every vendor, when they're presenting something, what do they present? You have to buy this, but what do we as a user get for this? You get faster scans, better images, the two things, right? So the sites, of course, buy this, and they want to implement this, just like what we did in the hospital. Scan faster, much more patients. But it came to my mind one thing, the waiting list. You will mention the waiting list, Doug. I mean, if you have a member which is in the waiting list because the MR takes so long, would you be thinking a little bit different if the waiting list is short, while your member, one of your family member, can get the fastest scan? That's something to think about, right? And another thing I was thinking about is AI is already here, like you mentioned, Doug. It was back in the days with the dot engine helping the positioning. And back then you can choose either to use that or not use that. But now it's built in the sequences. The statement I made was like, every vendor now is built in AI, just coming more and more and more. So if you choose not to use it, you will be far behind. It's like using the sequences without parallel imaging. So you scan one T2 for like 20 minutes, right? But in that kind of direction. That's what I meant about my statement. So take it, use it with care, and of course, validate, because there's a lot of papers now out there, and all vendors are coming. Yeah, that's my thoughts, though. Yeah.
Lovely, Bag. Thank you. And I think some of the questions were also involving asking if the literature is supporting these claimings we are making about AI, because they said people are a little bit conservative because they don't see peer-reviewed, they don't see, but I would say there are a lot of papers of people testing it, prospective, retrospective studies. So, I mean, it's just a matter of searching it, because you can see that AI is the topic of the day, I would say, and not the topic of the future. It's the topic of the day. Sam, and then Bag, and then Doug. Sam, would you like to add anything?
I want to point 3 things that Bag was saying, and probably the rest of the speakers can chip in as well. So one of them is the filter. So that the filtered images. So the images look like they have a filter applied to it. So that's one of the questions that we have from the attendees. They mentioned that they feel like some of the images, they are so filtered that they don't believe they are real. And how do the radiologists respond to that? What's the feedback? And that applies as well for CT, ultrasound, and mammography. It's not just MR. That's the first one. And then I have one that might go to all of you, but maybe Jan can reply to that a little bit better, I believe. Do you believe that one of the pushbacks with AI has to do with the terminology? People don't understand the terminology, so they push back on it because they don't know exactly what we're talking about. So we are always afraid of the unknown. So because we don't know what you're talking about, I'm fearing it. So that's another one. And going back again, the waiting lists. There was also a question about the waiting rooms and the fact that hospitals are probably not prepared to scan so many patients within an hour. When we were used to scan, let's say, 2 patients an hour, we have a waiting area that is prepared for that amount of patients. And then we have a huge amount of patients coming at the same time because you're scanning 4 or 5 patients in an hour. How do we deal with this different approach and workflows? So I'm playing a little bit the devil advocate here. So there's 3 questions: filters on images, terminology as a pushback, and the workflows that we have at the moment probably not ready for the AI implementation. So that's my question.
You gave me a massive job. Now will be very difficult to coordinate. Okay, let me think about Doug first.
Yeah, well, Sam, I mean, these are valid questions. I'm going to go with the filter. We can control the filter. Yes, you can go max, like what Bach was saying, and it can look my favorite word is cartoony. You can make those images look very, very cartoony. But then again, we can bring that back. You know, there's always that halfway point, and that's that building that relationship with the radiologist. I'm a big believer in that. So if you're trying something, again, it's down to what the radiologist is going to read at the end of the day. And then, you know, working with your application team, depending on what vendor that is. Hey, these images are looking too cartoony. What can we do about it? You know, AI to me is still brand new. There's a lot of work ahead of it. It's just like when parallel imaging came out, what Bach was saying. We had a lot of issues back in the day when parallel imaging came out, you know, with artifacts, especially with artifacts. I remember using those cushions, the cushions for abdominal imaging to help reduce artifacts. Again, this just comes down to it's still evolving. There's lots of work to do, which is exciting. But you know, I don't see that happening for, you know, what I mean, I was saying for another 5 or 10, at least 5 or 10 years. So that's it on the filtering.
Thank you so much.
Yes.
Amrita, would you like us to give us your opinion about from a radiology perspective as well, about what Doug said about filters? If you can give us a little bit more, if you want to chip in on the discussion.
I think from my side, I agree, Doug. I think anytime there's a question, I think that relationship between the MRI radiographer and radiologist is key, because any changes that you make to sequences or any changes within any other parameters, the output is the report that the radiologist will issue. So for all of these things, whether it's MRI or any other modality, the person taking the image and the person reporting on it that affects patient management both have to do it together. And I think that in all the cases that I've seen, so long as there is symmetry between those two, the partnership that is required helps the integration come in, because it's not one person. It can't possibly be just the radiologist or the MRI radiographer. So I completely agree.
Absolutely. Jan, anything to add on top of this from your perspective as well?
I mean, maybe the question right back to Doug and Amrita, what is a real image, right? And again, right, I mean, all those images are like post-processed, right, translated into something we can read and understand. And I think, look, one thing is important, that the representation of an image supports answering the clinical question. So when we can improve, right, image quality in the sense of, hey, it helps us more to kind of figure out and answer the question that has been asked, I think this is the right direction. With regards to Sam's point on terminology, look, I fully agree. We tend to, and also in this session here, I think we mentioned AI as a term maybe 300 times, and maybe just once or twice the word machine learning. Yeah, so we generalize a lot, and maybe for this audience it's okay. Yeah, but of course, as we get more into this technology, as we get more, all of us, into more like adoption, as we get more and more involved into maybe multidisciplinary teams to implement those technologies in our practices and departments, we need to start differentiating, right, and being a bit more precise on what we do and how we do things, what kind of capabilities we use and which ones not. So, but look, terminology is relevant in a very different aspect as well. We have to, I mean, as an industry, right, let me say, we have done a great job in radiology in terms of pushing adoption. Yeah, we have, as an industry, have built great AI technologies, great products. We have worked on integrating them seamlessly into radiology workflows, and so on and so forth. One thing I think we have, right, we have built those great regulatory pathways to get to AI products, which we can purchase as a provider. But one thing I think we have not done well enough, and this is building trust with users. Yeah, so I think there's huge effort more on the vendor side to educate, right, to kind of demystify, as we said earlier, and to kind of start building this trust, which is so required with the technology, which is not I mean, precisely explaining how it comes to, for instance, a recommendation or conclusion or prediction.
Thank you, Jan. Actually, would like to ask you something about the validation of this algorithm. How can we ensure accuracy? But I want to go back one moment to Amrita because I can see she has the hands up. Amrita, would you like to add anything about what Jan said?
Thank you, Julian. No, Jan, I completely agree. It's just to build on what Jan is saying. I find that obviously the conversation with AI right now focuses on implementation, all the technical side of things. How do we implement it? How do we monitor it? How do we evaluate it? But actually, that's just one part of its role in clinical practice. The bigger part is the change management. And change management essentially looks at the fact that people are scared of AI. They're scared because they don't know. If you start using deep neural networks, deep learning, it can throw a lot of people off because it's terms they just don't understand. And the reality is, even though right now we are radiographer and radiologist heavy who know, and we're a self-selective group of people who likely know what we're talking about, so everybody can sort of go with the conversation. Actually, when we're in a normal department, when there's 50 other people present, majority of those people won't know the depth to which we may well know. But we have to be very aware that in any clinical pathway, there are multiple end users, and that change management that is required for successful downstream implementation requires everybody to have a certain degree of comfort with everything. And that's when I agree, and the education component is hugely important, because education doesn't mean that you have to have a certificate in machine learning. What it means is there are now multiple courses so that people, the best way I can give an example is, so research, all of us who work in clinical practice know the importance of research. I am not a professor of anything, but I understand the principles of research and why it's important to weigh up data when I'm reading papers and what evidence-based medicine is. So I know the principles by which I will judge whether one paper is better than another paper. AI is the same. There has to be upskilling of the entire department and eventually all healthcare workers in any given country, because they have to be comfortable with the terms they're listening to, whether it's regulations, whether it's governance, implementation, evaluation, but not deep, but enough to know, or the ethics of it. They have to be aware of all the different facets so that they're not afraid of it and they can partake in the conversation, have the positive and negative comments have to be taken into account and address the concerns of those who have it. And I think then you'll get true change management and it'll become like normal where all of us have, digital phones and laptops because we've accepted it. Everyone knows the pros and cons of, all of these things. So the upskilling has to go side by side. And to that point, as Christina mentioned in her presentation, she runs formal courses for radiographers. There are lots of national bodies that are doing free education courses that we're doing just so that you can upskill, because the more people who are aware or have a certain level of understanding of all the different facets of AI, the easier they will be to be part of any projects that are happening, and the uptake of it will be better.
Sam, I can see you're looking forward to jumping in on this discussion.
Just one small comment, because Dr. Amrita is talking about education and learning, and we have a question from Samuel Pistis. Sorry if I'm butchering your name, it's not on purpose. And he actually said, what is the purpose of learning the basics if everything will be AI in the future? So I think it fits perfectly in what you're saying in terms of we have to learn with AI and not just AI. So what's your thoughts on that? I see Jan is also shaking his head and back as well. So I believe everyone wants to chip in on this one. So please go ahead, Julian. You can manage the hands, I think.
Actually, I think this is also the right question to start with Doug, because Doug is the man who framed the word back to the basics, no? But Doug, so what would be back to the basics? What would be defined back to the basics? We know you have this book called like this, but what about when AI will kick in? Are you going to do another book and say back to the AI basics or something like that? My mic, please, Doug, just you're on mute at the moment.
Sorry about that. I apologize. I'm going to agree with Dr. Kumar on a lot. I mean, it's about, now I'm going to go back a few years when we started scanning pacemakers. We were all scared about scanning pacemakers until we understood it. I've been, in the field for over 30 years. And when I heard we were going to start scanning pacemakers, I admit I was afraid. I was like, oh my gosh, it was always a no. Everything was a no. Until we actually really understood it, and that we can scan patients with pacemakers safely. A lot of this non-label stuff that the researchers are doing is phenomenal, and at the end of the day, we're bettering patient care, because now we're able to scan patients with pacemakers that years ago were was a no. Getting back to the basics is understanding it. I love where AI is going, just because I believe it's going to inhibit that patient care, and that's why we're in this business. I hate to say business, industry. I think it's very important that we do our due diligence and research where it's going, and not be afraid of it.
Thank you so much, Doug. Thank you so much. So basically what you're saying is that the fundamentals, the pillars are changing as well, and we need to adapt accordingly. Do you have the same point of view back on this as a radiographer yourself? Do you think this is the right point to address?
Yeah, I'm totally agree with Doug. I mean, if you imagine you're sitting in a new car, let's say Tesla from now, and then you want to go from A to B, and then you put on a GPS, you want to drive here. So what happens then? You have to know the basic, right? The basic of driving, gas, brake, all that kind of stuff. It's like MR. So even though you have a lot of tools for help, like in this case, AI, you need to know how to handle the scanner. And another thing that came to my mind, that a lot of people are talking about SAR issues. To be honest, I don't encounter much of that at the newer scanner now. On the older 3T, yes, a lot. But that was also new to our hospital. We didn't know 3T. We were running it like 1.5, putting the sequences, all, like Doug mentioned, too much tube spin echoes. But a lot of people are not talking about how do you position your patient, how do you treat your patient, all that kind of stuff. And a lot of people are very interested in the protocols, interested in the sequences, in scan time, in the resolution, but few are very interested in how do you use your protocol. I think that's the key. If you know how to use it, it would be much easier, because there are a lot of parameters to control in there, like going from high RF to low, just to help you with the SAR, flip angle, if you understand that, a few parameters there. And yeah, that's what I had in my mind, and I wanted to share, and not jump into you guys, because listening to you guys was so funny and very interesting. So I'm just keeping for myself for now, and then thank you for having me to share that.
No worries, thank you, actually. And back also, I might involve Jan actually on this, because probably as a representative also of a very important manufacturer can address this as well. There were some concerns about MR safety in the group chat. People were saying, oh, AI will not play any role in the MR safety. The ultimate responsible person is the MR radiographer. And we ran an event on this. We had an event in November completely focused on MR safety, because our mission at Everything MRI is also giving something back to the community and improve the overall level of safety. We daily hear about accidents happening in MRI. So in which way do you think AI will help, if it's going to help with improving MR safety?
I mean, look, first of all, this is a fantastic example why radiographers, MRI techs will not disappear. Exactly this. I think safety is such a relevant topic in context of MRI. This is one of the main reasons, I would say, why human in the loop, right, how we call it in machine learning, is always very important. I mean, look, I think, right, ultimately, as you said, it's the radiographer, it's the tech who is going to be responsible, but maybe AI will support here as well. And maybe there are use cases. I mean, it's not an area we are doing or I'm not involved in any kind of research work here, but I could imagine there are plenty of different possible use cases how AI could help, right? For instance, also, I mean, right, simple like prediction algorithms telling you, hey, there was previous safety issue with this patient, right? Or I don't know, based on machine statistics or stuff. I mean, there are plenty of things eventually vendors could look into and very likely do as well already.
Perfect. I can see also back, we have a list of hands raised up at the moment. I think we can start with Bart, which I think raise it first. Bart, do you want to add anything on this?
Yeah, thank you. There's one especially thing that I don't like about AI. It's like a lot of people are mentioning, oh, we're doing much more now. So what happens when you feel pressed that you have a patient after patient after patient? It's easier to make mistakes, right? Because you have to scan so fast, you have to change the patients fast, and it's very easy to make mistakes. That's what I feel from my experience, even though we have to be much more aware of how you're working, because you have to take care of the patient after patient after patient. There's almost no room for breathing. So that's what I don't like about AI, all in all. But it's also an important topic when it comes to safety. But on the other hand, if you're scanning faster, we have a lot of kids at the hospital, so we're not able to do a lot of non-sedated MRI scans. So that's a positive thing. So it's always pro and cons, even though you are having AI. Yeah.
I think will be also a matter back of common sense among people in leadership roles, understanding obviously that turnover will be crucial at the end of the day, but exposing yourself and your company at the risks like this because you want to scan a patient every 5 minutes because you have, I don't know, the new AI algorithm that will allow you to do that will be a massive risk for you in terms of like, for many, many reasons. What do you think about this, Doug? Do you wanted to add anything about this?
Yes, bring your leadership and get them involved and do a walkthrough from start to finish so they can actually see how your daily schedule is. I believe, they don't want an accident to happen as much as you do. But if you show them your workflow of, scanning every 15 minutes, now it's getting worse. An accident's going to happen. It's not if, it's just when. One of the other things I was going to just bring up real quick that I've seen with AI that I'm extremely excited about is that in the EPRs, you can just type in implant, with that patient. Instead of going through 750 or 1,000 pages, it's going to bring up that implant or aneurysm clip or spinal stimulator. So to me, I think that's a huge positive because we've all gone through those electronic patient records, and it takes forever to go through page by page to find out what surgeries they've had. So but getting back to the burnout, we're seeing it now, especially this last year and a half with a lot of incidences here in the US that every single one of them could have been prevented. And I believe working with your leadership team and giving that voice back to the tech and explain this is the workflow, I believe will help in your department.
Perfect. Thank you, Doug. I think what you said makes absolutely sense. And these essentials will be perfectly established and clear, especially for people in leadership roles. Sam, do you want to add anything on this?
I have 4 points in terms of MRI safety. They're very quick. So one of them is about implants, as Doug was just talking about. There's this lovely platform called Nord Insight where you can just type your implant and it will search the whole internet and find you if that implant is compatible or not. So that's one of the ways that we can use AI for safety MRI practices. So it's very useful. You type it, you find it. You don't need to go to their website. You don't need to go to the manufacturers or to the list. There's just a link. You just type your implant. It will give you the information. So that's point number one. So then it's about remote scanning as well. I think remote scanning will basically split the way radiographers work nowadays and will have more than one role. Nowadays, we do everything. As Amrita was saying, we do the admin, we do the acquisition of the images, we do the patient safety, we do everything. And with remote scanning and the advent of AI as well, I think we'll have a profession where the tasks that we perform will be split in different areas. So you might be a radiographer that loves to do patient positioning, patient care, patient safety, and that's your role. And you can be a radiographer that loves to scan only, and you're going to be that only. So I believe that the radiographer technologist profession will be completely different in the near future. So that's another one that I believe AI is going to help a lot. And then we have VR tools that we use nowadays to train people. So again, as VR and AR, we can use it in universities and of course in hospitals to train the radiographers and the students in terms of MRI safety. I think it's very beneficial for everyone to be using those, and you can see the OEMs already using those tools themselves. And Jan from GE might attest to that. They use it to train their people how to put their scanners together, the safety side of it. So they are using it. There's no point, there's no reason why we can use it as well. And I believe holographic technology will play a massive role in the future as well. I think the fact that we can be in the room without being in the room with holograms will also be something very interesting to explore in the near future. But that's just some ideas in terms of MRI safety that I have as well.
Perfect. Jan, anything to add of what Samuel said?
Yeah, just to what Doug said and Sam said with regards to like implants, for instance, right? I mean, great example you shared, Doug, about kind of figuring out from the EPR or patient record, right? Is there an implant or not? Right, and Sam, you mentioned this website where you can see if is it kind of working, can you go ahead or not? I mean, look, this is all like reactive use cases. I mean, think further, right? And think about if AI, right, that is around you kind of ambiently, that it can tell you upfront, right? You don't have to kind of actively get into this task to figuring out. No, you get it presented by AI technology that is somewhere implemented into your existing workflows and telling you, hey, look, you can go ahead, it's going to be safe.
Thank you, totally agree. One kind of like similar point that we already discussed, but it was also a matter of a lot of questions. What was about the reliability of like different algorithms? Like I can give you one, for instance. One was saying, how can we establish trust in AI algorithms? Should we simply assume that any images generated by these algorithms are accurate without any question? So Amrita, I know you mentioned this in your presentation about validation, make sure there is appropriate training. But one question I have myself is, we know that there are plenty of algorithms. Like people maybe, you know, they just hear like names here and there, but how can we ensure like accuracy and also reproducibility of the results? How can we make that?
Thank you for that. So in terms of obviously, I suppose the starting point is that whether it's MRI imaging, ultrasound, chest x-rays, mammograms, all the different use cases where AI is currently being used, it's not in an autonomous fashion. Right now, almost certainly for all clinical decision support functions, AI is being used to augment the radiologist's opinion or to expedite or to triage and prioritize. So the final say is always the radiologist. So when it comes to actually who has governance over that report is the radiologist who chooses to agree or disagree with the AI's sort of output for that image or for that particular modality. In terms of reproducibility, that's something that I know that when we initially test out different AI algorithms, we do an accuracy stage where we just to make sure that our operating points for all the different things that the AI picks up on that particular modality is at the correct level for our equipment, for our patient demographics, that it takes into account with sort of our results that we already know. It's a test that we run so that the AI can show that it predicts exactly like what we have evidence of it predicted when it's just a human reader reading the report. So almost every single evaluation or real world deployment we've done has had the initial accuracy phase to make sure that the results are trustworthy. And it's interesting because in one of the cases, we actually found that we had to change the operating point to pick up subtle cancers because we can't be in a position where the AI doesn't pick up. Even if, say, 49% of the radiologists may well have missed this cancer, when you know it's been read and picked up by a particular radiologist, AI has to capture it. But I think in the initial accuracy phase and the testing that you do, you can make sure that it is a trustworthy and that the results are reproducible compared to whatever they have published.
Amrita, I just have a question, actually was from the attendees in regards to this trust situation. Because some of them and myself, we think about the bias of training these modules. And we know most of the data sets that we train this model on, they are from Western civilizations. So we had, for example, someone on the attendance that is from Africa and is asking how are these bias being pushed back or not, because from us from Africa, is this data being implemented on these tools as well? I know you have a lot of experience on that, so I would like to understand that myself too, because I know most of these modules are trained in certain sets of data. And let's say, for example, your institution has a module and has an algorithm that they're using for, let's say, breast screening. And then another hospital has another module that was training a different data set. And the patient is seen by one of your consultants, but then needs a second opinion and go to the other side and has another algorithm there. How do we combat that bias and that difference of opinions with different algorithms?
So thank you for that, Samuel. So the way algorithms work, very simplistically, this is like how I made myself understand it. So the training of algorithm is separate, because obviously if you're a company, you have access to a training data set and you try to ensure that there is reproducibility across multiple patient demographics, different that have been put through different equipment, say, from different manufacturers. And within that, you have your internal validation set, because once you've trained the data, you need to see now, does it work on a different set and give you the results? Then you actually have an external validation that is something separate from the company. But by the time it comes to someone like me who's sitting in a hospital who actually wants to use it because they've gone through all the regulations and now it's ready, it's got the approval for whether it's UK, EU, or FDA, one of the first things I look at is what they trained the data on, because it has to be reproducible, because especially in my demographic, it has to represent the multitude of demographics that are sitting in my population base within Southeast England. So, and it also has to reproduce the fact that I may have 3 different vendors and 3 different hospital sites using different machines. And there will be discrepancies between all of these factors. But I think I know that every time we have looked at vendors, we have gone back to see, the first question was, what was the training data? It's very important, because to your point, if a company has done all the training and all the training data set came from, say, Korea, and now they've relocated to a country that has not got that patient demographic or that equipment, it needs to build it into their algorithm. This is something that can be developed, but you have to have the foresight to know that you will require extra training data, so that it ensures that the results are reproducible for the whichever demographic you're looking at. But I always look at the demographics to make sure that it does take into account. And again, it's not to point fingers those who have and have not, because it's something that's ongoing. The fact is, if an algorithm is not representative of something, then they need to get separate from clinical live deployments. They need to train for their next version of algorithm that could solve for whatever problems they're having, and then upgrade to the latest version that's got the appropriate, say in UK, the MHRA approval for that upgrade.
Do you think this is something that is hindering broad acceptance of AI within the clinical field?
So, I mean, we have chosen in the NHS the way we're doing it, because we have to show end-to-end process implementation operationally. So we've, say, for example, through the National AI Diagnostic Fund Award, we've chosen chest x-rays, because if we can show for a simplistic chest x-ray the end-to-end deployment and all the evaluation metrics, then we have a governance framework that can be replicated across multiple use cases. Now, there are, I think when we did the procurement, there were 72 suppliers who could offer a chest x-ray product that we were looking at with our various specifications. Obviously, there was a lot of repetition, because you have different suppliers who and different providers who may well be offering the same supplier. But say, even if you come down to the top 10 suppliers who may be there in chest x-ray, actually a lot of them, because it's a simpler modality, especially simpler than MRI, they may well have started out on one countries' training data. But if you look at all of them, they have been going from continent to continent and adding it over a period of the last 5-6 years, so that they are actually deployed, whether it's America, Europe, Africa, India, or Southeast Asia, they are deployed everywhere. So it's quite representative. And I think over time, this will happen. But the main thing is to be, again, through upskilling, that people are aware that you do have to look at the training data set, because obviously every vendor will say their product is great, but it has to be representative to your particular population set and equipments.
Perfect. Thank you so much.
Jan, do you want to add anything on this? Yeah.
Yeah, I mean, I fully agree, Amrita, what you said. Maybe just to add two things. One is, right, directionally, when I think about the future, when I think about this potential of, right, this new generation of AI, I believe we'll move into a future where we do a lot of fine tuning on site, right, with the specific patient population you have to deal with, right? So kind of customizing the model. This is something we'll get into. I mean, we all know it's early days of AI, even if we're still talking about many years. I mean, I started AI and MRI in particular in 2007. Yeah, so long time ago. But it's still early days. When you look into the adoption rates across Europe, across the globe, I mean, it's pretty low still. So one thing is, right, fine tuning is going to happen at a customer level, if you will, at an institutional level, very likely. And secondly, what we as an industry have to do also much better in the future, the more we kind of, or the more AI spreads out, is what is called ML ops, ML operations. So meaning monitoring and making sure that we don't see, for instance, a model drift or a data drift, right? And make sure those technologies work well. This includes, of course, the human in the loop to give feedback, as you mentioned, Amrita, but there are also other technical capabilities that are factored into ML ops to make this work. So just wanted to point out those two things.
Go ahead, Amrita, don't worry. You first, please.
Yeah, and I completely agree. I think the monitoring side for the algorithm drift, as we move sort of downstream from you've had the integration, you've had implementation and adoption, now you're even evaluating. Monitoring is a continuous process. And as we get into the real world deployments, monitoring falls into the post-market surveillance that is required by the supplier to adhere to their regulatory needs, and then the post-market sort of clinical follow-up that is required for the provider side of things to make sure that there is no algorithm drift, that there is no sudden variability in the accuracy or positive or negative predictive value, through which now obviously broader conversations, whether that's vendor supplied and helped for the provider, or if it's through an AI platform, these discussions, because I know that in the UK, at least, we are now moving towards real world deployment. And for that, the monitoring bit is coming into light, monitoring and obviously reimbursement, because those are two things that are the next two hot topics. We know America is moving forward with reimbursement codes in various forms, but UK and Europe and other countries have yet to follow in something fixed. But monitoring is something that obviously is going to be most probably the next bet, because everyone is looking at it. And we know that we can't go live until we have that active monitoring. For one of our initial pilot studies, we did the manual monitoring. It was just too much of a task for us to do it on a real world deployment basis. So that function has to be automated and looked after. So I completely agree.
Both actually, but I want to involve back Doug as well, because we covered this as well, but I think people might still have a little bit of concern about liability. So we are discussing more and more and more about implementation. What if something goes wrong? Meaning, who is the ultimate responsible? Because, I mean, logistically, it might come to my mind, it might be the company who has provided the algorithm, but I'll give you a scenario. This is, I know, something very basic. Like the Doug modus operandi, go back to the basic. So imagine like a radiologist, Amrita, reporting a scan, and he's not used to this new images provided, I don't know, by that specific algorithm. Might miss a lesion because, oh, these images are too plasticky, I confused the lesion. So who's the person ultimately responsible? Is that the radiologist because maybe they actually missed the lesion? Is that the vendor or the company who has provided the algorithm for not clear training? So how are we going to face this as well?
I could give you my opinion. I'm more than welcome for everybody to join in. Now, it's not as simple as that. Now, if you look at it broadly, and again, I'll go back to what's happening in the NHS in UK. If so, the two people who could be liable is the company and the provider. So for us, it would be our hospital because the radiologists work through the hospital. If the AI misses and then the radiologist misses and it's a clear miss, it would still be the hospital provider that has liability because the AI is, as in its current form, an assistance, a diagnostic aid to the radiologist. But if it is found that there was some actual error, processing error at the level of the AI, so for example, you said plastic image, that therefore now it's deterred you picking up the abnormality because there was a big problem with the image, but that would be reportable. I mean, then there's regulation in place for the company to immediately report that back through their regulatory pathways. So, but then it becomes a bit of a black box thing because then so long as corrections are made and whatever needs to be done, they can be safe. But the overall thing will always be that if a report is issued and the radiologist was happy enough to issue a report for whatever reason that they thought that was a absolutely technically right image, it'll always be the radiologist and therefore the provider. You know, it'll never be anybody else because it's an assisting and diagnostic aid device.
Thank you so much for this explanation. I think you addressed basically a lot of questions coming from the chat box.
I'm happy to be questioned. This is my opinion.
And back, Doug, do you think there might be also some potential liable situation for radiographers as well, where perhaps working with AI implementation, there are potential risks for radiographers as well, a situation that you might say, not sure who is the fault in here. Maybe we can start with Bach and then we move to Doug as well.
Yeah, it's a very difficult kind of question actually, because whenever you get this tool in your hands, you need to, like us in the beginning, we did double scans just to check if what we are seeing is correct, right? Not filter, but raw data on, AI off, and so on and so on. And then the next thing, the radiologist, you need to work closely to the radiologist, the physician, to make sure that everything is on the right track. You know, this is not standalone work from a radiographer, no way, because you cannot decide what the radiologists want, but work as a team is very important in the early stage. And by that, I mean, this is just another example. Back in the days, whenever you are optimizing a sequence, you have to trick the radiologist, right? So beyond AI, you have to, if there's some specific sequence, you scan it each time, and then the radiologist, I don't need that sequence, and then he or she get used to that sequence. And the one time you're not scanning that sequence, believe me, he or she will ask you, where is the sequence you usually give me? You know, they need to get used to reading AI and watching AI images. It's, from my opinion, though. Yeah. Doug,
any thoughts on this?
Ditto. I mean, that's, you know, when I was talking about before, that's why it's vital to build that relationship with the radiologist. When I was in practice full time, because I'm teaching full time now, I had that relationship with the MSK radiologist, the neuroradiologist, the body radiologist. You know, at the end of the day, they're reading that study, so they're ultimately responsible. You're there to provide the best picture possible. And yeah, I completely agree with Bach and Anita on that.
I can see also Jan would like to add something to this conversation.
Yeah, I mean, just right from my perspective, right today, right? I mean, the current state of AI we talk about, and Amrita, you mentioned this, like assistive technologies, right? I mean, there's a reason why, for instance, all those tools that are there for the radiologist are called clinical decision support, right? It's supporting you to do something. And you should see it the same way. Let's imagine we have some AI technology that supports you in terms of AI MRI safety, I'm sorry. Yeah, it is an assistive technology as of today. Yeah, so you are responsible for the oversight. You are responsible for the process, and this technical capability is just supporting. I think this is how we should see today. Maybe this should, or maybe this will change in the future at some point, but this is what it is today. And actually, I think right, liability is a very interesting topic, because maybe it's also one of the reasons why adoption in healthcare is slow, right? Don't comment further, but just think about this, right? Because what we see a lot is that there are radiologists with those clinical decision support tools that are using AI, right? Reviewing the AI result, but then reviewing the entire case again to just make sure, is AI truly right? And I mean, this is interesting, but it's the opposite from getting those efficiency gains we're expecting. Yeah, so it's just all about trust and liability. So that's a whole area which I think we have to, as an ecosystem, have to evolve on and kind of tackle differently going forward, the more we adopt those technologies.
Okay, thank you, Jan. And I can see we are approaching the 3 hours and a half of event. I think we covered quite a lot, I have to say. I know Samuel has probably a final questions, unless the speakers would like to add anything on top of this conversation. Samuel, go ahead.
Thank you, John. Yeah, we're approaching fast for the end of the event, so I want to leave with a final question for all of you. But of course, if you want to give final remarks, each one of you, please feel free to do so. So my question is, in '95, the first AI algorithm was approved by FDA. And I wanted to ask you guys, how far have we come so far? And where do you see radiology in the future, in the near future with AI?
Who wants to start? Difficult topic, this one.
I mean, I can start if you want. Look, I think when we think about, again, right, this term clinical decision support, we talked about this a lot today. I think in the very near future, there will be no radiology case which is not like read by the AI prior to the radiologist reviewing it, right? So everything will be like pre-processed by AI, if you will. I think that's the direction, right? We briefly talked about maybe the evolution of the role of the radiologist, right? Maybe also taking responsibility for some other clinical domains more and more, right? Fusing domain insights, as I called it. And look, I think as like in our private lives, right? And when you think about the usage of your smartphone, your Siri, Alexa, all those tools out there, right? How naturally you are using this day to day. I think AI will slowly but pervasively come into all aspects of clinical workflows and will step by step, right, be implemented in more and more kind of use cases, and will hopefully, right, get us to efficiency, better productivity, better quality of healthcare overall. And at the end of the day, really, hopefully improving patient outcomes.
Perfect. Amrita, I think you wanted to add something as well. You had your hand there.
And thank you for that. I think for me, the future will be, and again, this is most probably, I'd say most probably 5 to 10 years away, is multimodal imaging. I think right now we're getting comfortable with AI in a particular modality, and we'll bring them in, and all of it will come together, whether it's CT, MR, PET, CT, X-rays, and then you'll have the processing when you're actually doing multiple modalities together to sort of more address possibly even preventative and predictive insights, as opposed to just reading one single report.
Okay, we'll mark this forecast for the 2025 AI Forum to see if this happened or not. So it's your responsibility now. Doug, would you like to add anything?
Yeah, first, I want to say thank you guys for hosting this event. It's a great subject, and I think it's going to continue for many, many years. And I want to thank my colleagues too, Jan, Anita, Bach, Julian, Samuel. I think this was awesome. Lots of great input. My final words would be, build that relationship with the radiologist, get with your leadership team. If you have a lot of concerns, you need to have your voice. Show them your workflow. I think workflow is extremely important. We're visual people. So I think if they see it, then just talking about it, they may understand, where your concerns are. Obviously, with what's going on today, we, as a technologist, we need to be smarter. And like what Bach was saying is it's a tool. And how we use it is gonna, we can use it. There's many benefits that we can use AI to benefit the industry. And again, you know, my big saying is at the end of the day, it's all about patient care.
We can also reframe your big statement, Doug, from don't wait for tomorrow for using AI, start today, right?
Yes, exactly.
Buck, do you want to add any final comments on this?
Well, I guess Amrita, Jan, and Doug already told everything, but nonetheless, I'm very happy to join you in here today, and thank you for all who participate here today. It was very interesting to see what people are thinking about AI. And to be honest, I don't think AI will replace the kind of work we are doing today, because what we are doing today is so valuable as a human being. I mean, another example for me is like, let's take it just in a simple liver exam. If AI cannot do the automatic talking to the patient, the care of the patient, you know, you as a human have to do that. So improvising. AI cannot improvise for you, but AI can be a really good tool for you to get those kind of images you want. So within the next 5-10 years, I think AI will just come more and more and more. And already now I read about that the higher field strike at 70, they're using AI just to lower the scan time and even get better images, what they're having today. And then we also see the lower field strike at 0.55 implementing AI and making a super scanner, you know. And yeah, I'm just really happy that in my short career, I'm experienced something new, like extremely new, like AI. Because when I read about MR, it's like parallel imaging was like the game changer back then, but I never experienced that. But now we, as a young you, Julian, and Samuel, we can now experience AI as well. So I'm very happy for that.
Thank you for that, Buck. Samuel, what else to say? It has been a fantastic educational forum. I want to thank everyone. And I just want to pass the word to you for some final remarks. Again, thank you so much for joining us today. Thank you, everyone.
Thank you, Joe. So basically, I just want to thank all the speakers, first of all, for taking the time to do the presentation, to being here with us today. And of course, to all the attendees that took the time on a Monday evening or morning or afternoon, wherever you're based, to join us in this exciting conversation. And of course, I want to thank 𝐷𝐷 and Pearl Technology AG for sponsoring the event. But I can't go without saying a personal thanks to Julian. You've done a stellar job conducting the whole event, and you really need that pat in the back. You really did a great job, and I appreciate you. Just before we go, I want to let everyone know that we have an amazing podcast going on. Next episode is going to be released next week. It's about MRI applications, so please just check it on Spotify, YouTube, Google, Amazon, whatever you choose to look at it. And we have an amazing YouTube channel that Julian kindly runs as well, with a lot of free content there. And of course, our LinkedIn is super active with a lot of content that we develop every week for free. Everything we do is for free. It's for you guys. So thank you very much for exploring the world of MRI with us. Appreciate you all.
Thank you so much. Thank you, everyone.
Thank you.
Thank
Bye-bye.
you.
Thanks, everybody. Thank you.
Bye.